Okay, OB neonatal care. So there are going to be a couple of changes. One of the most notable changes is when it comes to CPR of a neonate. Remember, can anyone tell me how high that heart rate gets for brand new babies?
Like 200 something?
205, pretty fast, right? So we'll talk about it a little bit deeper, but it doesn't talk about it specifically. When it comes to pediatrics, especially neonates, if we see a heart rate less than 60, we're doing CPR. Okay, they're non-perfusing at that point. If they need 205 on average or right in that range, even if it's, because I think it's anywhere from like 110 to 205, 60 is still too low, regardless of how we spin it. So I just want you guys to make note of that before we get going too far, because it doesn't explicitly say it in here that I remember, but just something you do need to know. So most deliveries occur in a hospital. Most people nowadays are prepared for babies, right? They know they're pregnant, they know they're gonna have a child, they usually get the care they need. That said, there are demographics, or just folks in general don't take great care of themselves, but then there are also demographics where we are their birth plan, okay? Like, for example, a lot of our refugees. You'll come to find you actually have an appreciation for refugees because they actually understand that they're gonna call for a real emergency, which childbirth being on that list. Okay, now occasionally, pregnant woman's unable to get to a hospital, and then we have to make some choices. Are we gonna stay on scene and deliver, or are we gonna get them to the hospital and let them deliver there? Okay, and I'll teach you kind of how to make that choice. Sometimes the choice has already been made, you don't have much option, you're hanging out where you are, okay? So, a little A&P, once again, female reproductive, we're talking biological females having babies. So the ovaries, 2 glands, one on either side, okay, each on either side of that uterus there. Similar function to the male testes, obviously the female version, right? So they release the estrogen, they release the progesterone, the hormones in there, as well as the formation of the ova, right? The eggs. Ovum being one egg, ova being multiple eggs, okay? So each ovary contains thousands of follicles, and in each follicle there's an egg, okay? And then the idea of ovulation, approximately 2 weeks prior to menstruation, okay? Which if you think about it, if it's on a monthly rotating basis, woman has her menstrual cycle, has a week off, next week they're ovulating, okay? We're not gonna really talk too much about ovulation, but one thing I did learn is we consider a full-term baby, we'll talk about this again, to be 40 weeks, okay? I learned from a gal who's had several kids that they actually count it 42 weeks. They include this 2 weeks of ovulation as well in your pregnancy time, okay? So just something to keep in mind, nothing huge on that. And then the fallopian tubes, so extending off of our ovaries or off of the ovaries into the uterus there's going to be that associated fallopian tube with each ovary, okay? Now fertilization occurs when the egg is inside the fallopian tube. So perfect world, mommy and daddy love each other, make a baby. The sperm cells meet that ova in the fallopian tube, okay? And if all goes well, once those merge, they form what is called a zygote, Z-Y-G-O-T-E, zygote. And then that zygote will then float down into the uterus and attach somewhere in that uterus so the baby can start growing, okay? What if it doesn't make it there and it lives in the fallopian tube? What do we call that? An ectopic pregnancy, right? Which is a life threat. Once again, getting on the high horse for a moment, only real treatment for an ectopic pregnancy is an abortion. And then, like I said, fertilized egg or the zygote continues down to the uterus where implantation occurs. Okay, so the uterus, muscular organ, closes and protects the fetus as it grows. This is hollow or solid? Hollow. Hollow, right? It holds stuff. So it's a hollow organ. So the uterus, being muscular, is what produces those contractions during childbirth. Okay, helps to push the fetus through the birth canal. And then the birth canal is made up of the vagina, the lower third of the uterus, which we call the cervix. Okay, so once again with the cervix, when they say we're dilated to 10 centimeters, they're talking about the cervix. So we're talking about that kind of sphincter between the uterus and the vaginal canal there. We want that at 10 centimeters to make space for the baby, which is about this big or so, okay? If you're planning on going to medic school, you will spend time in the L&D department. I was told that I would be checking people's dilation levels, and I was like, okay, super scared, don't want to do that. So I walked in the first room, like, I'm here to check your dilation. And then I got a resounding, hell no, you're not. And I said, okay, I'm gonna leave. And so I never actually got to do that. But I did get to play with their wall. They have a big wall full of different sizes. So that was all I really did. But you're gonna have to get used to that, right? But you are gonna see this if you do move on to medic school. It is something that you're gonna wanna know about. You'll do 2 rotations through labor and delivery. One thing I can say about my experience is it was kind of refreshing going in there. Not often do people go to the hospital and they're happy because whatever happened, right, when they're leaving. That doesn't typically happen. So it's kind of a neat area. It's a neat space. That said, brings a different level of stress to everything. Yeah, Isaac.
Where'd you say it gets stuck at in the ectopic pregnancy?
Fallopian tube. Yeah, so question, where does the egg get stuck? Fallopian tube for an ectopic. I gotta repeat questions because we're filming. So, okay. Here's a picture. This is what the baby looks like when they're growing in there, okay? Now, one thing I want you to pay attention to is the location of this placenta up here, okay? Now, the placenta can attach basically anywhere inside that uterus, and we'll talk about in a little bit one of the areas, if it attaches there, where it's gonna be a problem. Any guesses just looking at that picture where if that attaches somewhere, it's gonna be a problem? Over the cervix, yeah. If it's blocking the exit, that's a problem, okay? But we'll talk about that as we move on. Where is it at? So things to consider, right? We're dealing with the female anatomy, so this is the anterior, posterior aspect of it, okay? That pubic symphysis, that connective point in the front of our pubic bone, this is why that's important that it flexes. Or this is important that it flexes because we're making space for that baby to come through, okay? And then when we think back to trauma, look at that urinary bladder. It's getting smashed down by that baby. So the risk of rupturing that urinary bladder is pretty decent when we got a baby in there, right? Essentially, you've got a half full water balloon and you're putting pressure into it. It doesn't take as much force to break it, okay? Okay, and then the vagina is the outermost cavity of the female reproductive system, forms the lower part of the birth canal, okay? Otherwise known as the vaginal canal, like I've been saying. So it completes our passageway, or the passageway, from the uterus to the outside world. That is where the light is for the baby. That is the end of their tunnel, okay? And then the perineum is the area of skin between the vagina and the anus. This is a space that we don't typically care much for or care about typically in your average patient, but in particular with pregnant women, we do care about that area because it is not uncommon for women's perineum to rip or tear while they're birthing a child. Okay, so the breast tissue, the mammary glands produce milk. It's carried through small ducts to the nipple to provide nourishment to the newborn once it's born. If you guys are new to this world, welcome to the fact that babies drink breast milk, okay? Early signs of pregnancy is that the breast will start to increase in size and in tenderness as the milk ducts start to develop or the milk starts to fill in. I've heard it's pretty uncomfortable, okay? And then fun fact, the reason we're called mammals is because we have mammary glands. Fun facts. Yep, we don't have eggs and we produce milk. Mammals. Okay, so the placenta attaches to the uterine wall and connects to the fetus by the umbilical cord. The umbilical cord is that baby's lifeline, okay? Now let's think about this. We're not gonna go too deep into the anatomy and physiology of the baby, okay? But do you think that baby's breathing air? No. I know I've had this conversation with a few of you in here. We're talking about heart murmurs, but there's holes in between our atria and our ventricles. We're bypassing our lungs, okay? Babies bypass their lungs. They don't need to use their lungs because there's no air quite yet, okay? But that umbilical cord, like I said, is the lifeline. It has arteries and veins in it. Now, one thing that I think is kind of neat about the umbilical cord is that above your guys' scope, if you guys ever need to get access, IV access on a baby, you can use the umbilical cord, okay? It's kind of shaped like this. So that's the cord. I'm cutting it so we're getting a lateral aspect, okay? There are 2 arteries in there. And remember with arteries, they uphold their own shape. Think of veins like fire hoses. They don't have a shape until we fill them with water, okay? Think of arteries as more like your garden hose. They uphold and maintain their own shape, okay? And then we have one big vein, and I like it because it always looks like a scary face. But we can access that vein. Once we've, clamped, that's the word I was looking for. Once we've clamped that off, we can actually use that as an access source, or an access site. As long as the umbilical cord's still on the baby, which it'll be on the baby for your purposes for a while, right? Because we're only realistically going to be dealing with this kid for upwards of 30 minutes or so, okay? Questions on any of this stuff so far? Cool, all right, so, actually one more thing I want to draw attention to. The tip top here, the fundus, okay, the peak of that cervix. That's an important place to, or excuse me, that uterus rather. That's an important place to note because we are going to be doing what's called a fundal massage after child delivery, okay? And I'll get into that in a moment, explain what it is. So after delivery, baby comes out, the placenta is going to separate from the uterus, okay? And then it's going to deliver itself. The umbilical cord, once again, lifeline to the fetus. The umbilical vein carries oxygenated blood from the placenta to the fetus. The umbilical arteries carry deoxygenated blood from the fetus to the placenta. Remember how I said there's 2 times that it kind of gets screwy? Once is the pulmonary system, this is the other one, okay? Once again, babies don't have lungs. They don't process blood the same way, okay? And also they're getting kind of that excess blood from mom, okay? And then on top of that, veins, arteries, right, if we're going from placenta to fetus, vein is going from body to heart. We're talking about baby's heart now, okay? Arteries going away from baby's heart. And then the fetus develops inside a fluid-filled bag-like membrane called the amniotic sac. Okay, the amniotic sac, if we come back to this picture, is this kind of yellow highlighting around the baby. That's that amniotic sac, okay? So it contains about 500 to 1,000 milliliters of amniotic fluid, okay? Think about all the times we have fluid in our body. What it does, it's a buffer, it's a cushion. Amniotic fluid's no different. We're protecting the fetus, okay? It's kind of a buffer if there's contact. Hopefully the fluid absorbs the impact, not the fetus itself. And then fluid is released in a gush when the sac ruptures, usually at the beginning of labor. Not everybody has that. That's the very stereotypical, my water broke, okay? That's what when you think about the movies, that's what's happening. That amniotic sac is rupturing. Now, very rarely, it's like 1 in 80,000, babies are born in that amniotic sac. And we actually have to rip it apart, okay? I know one medic, like I said, very rare. She's kind of a magnet for the less fun calls, shall we say. And I know she's delivered 2 babies in the amniotic sac. She described it to me as kind of like tearing through like a thicker cellophane or a thicker like plastic wrap, essentially. Okay, so you can either rip it, we'll talk about it later, you can rip it, you can cut it, you have options. Any A&P questions so far? Okay, so normal changes in pregnancy. The woman's body has to adapt, it has to change. It's now carrying 2 lives, right? So you're gonna see a lot of changes, a lot of normal changes that are not directly related to the reproductive system. Okay, think about all the functions we need to do. We still need to perfuse the mother's cells, right? So there's going to be some increases and some changes. The big 3 being respiratory, cardiovascular, and musculoskeletal. Okay, there's going to be 3 of those categories, and we'll go into what each change looks like here. On top of that, hormone levels increase, right? Obvious reasons. We're now producing, or there is a child growing in there, trying to keep hormones going for fetal support, okay, and then help prepare the body for childbirth, okay? A lot of changes starting to happen to the mother's body as well. And then the uterus. The uterus usually lives down in the pelvis, okay? That's kind of its safe little protected spot. Think a baby can grow in our pelvis? Unless you want a weird shaped baby, right? I think of like those watermelons that grow in Japan that are squares, you know, same idea. But when they're pregnant, right, that uterus has got to lift out of that pelvis. So it's going to be displaced. It's going to be moving up higher than it normally lives, okay? Well, if the uterus is higher, that's where the baby grows, increases the risk, right? It's no longer in a as protected area, okay? So rapid uterine growth, when we start seeing that actual, baby bump, that tummy starting to grow, usually during the 2nd trimester, okay? So what does tri mean? 3. So how many periods do you think, not periods, that's not the right word to say. How many sections of a pregnancy do you think there are? There are 3. They're trimesters, okay? So first, second, third trimester. How long do babies typically live in the body or in their mom?
9 months.
9 months. So we do some quick math. Each trimester is about 3 months long, okay? So as the uterus grows, pushes up on the diaphragm, right? It's been displaced upwards, so that uterus is starting to get bigger. Well, our diaphragm stretches down, okay? So that uterus is kind of impeding the diaphragm's track, okay? So their breathing is going to start being impacted because of that uterine movement. So their respiratory capacity changes. They can't take as deep a breath because their diaphragm cannot extend as far down, okay? Well, kind of the way our body always supplements or compensates for things. If we are having, like, for example, bad blood pressure, what does our heart do? If we have a low blood pressure, what's our heart do? It goes up to compensate, right? Same idea. The their tidal volume is going down because of where that fetus is growing. So their rate is going to increase. Okay, but we are still going to see a decrease in the minute volume because once again, the tidal volume is disrupted. Could someone tell me the equation for the minute volume? How do we find the minute volume? Tidal volume times what? Respiratory rate, yeah. So our minute volume is tidal volume. How much air per breath are we pulling in multiplied by how many times a minute are you breathing? Put those together, total air moved in a minute. We're still going to have a disruption there because once again, tidal volume is dropping. So blood volume will also change, gradually increases. We're perfusing 2 bodies now, okay? They're going to have more blood in their body to start accommodating for that fetus in the uterus, okay? So it allows for adequate perfusion of the uterus. It also prepares for blood loss during childbirth. Women do bleed during childbirth. The average is basically a monster can, okay, or a tall can. That's about the average amount of blood that a woman loses during childbirth, okay? So if we think about that, if you ever spill just a little bit of water on a linoleum floor, it looks like a lot of water. A full can full of blood on the floor is going to look like a lot of blood, okay? Keep that in mind. Just understand it is normal for them to bleed, but we don't want them bleeding too much, obvious reasons, okay? Now, more changes to the blood. They have more red blood cells, once again tying into perfusion. We need to perfuse the uterus. We need to perfuse the fetus as well, okay? Their clotting factors increase. If there's any sort of trauma, the body wants to be able to heal itself quickly, okay? But remember, as the body tries to do things, sometimes it tends to kill itself, okay? Puts itself at some increased risks if we have more clots floating around, right? Especially if we're talking the big 3, MI, stroke, PE. And then their heart rate is going to go up. Their heart rate increases by about 20% to accommodate for all of that excess blood. Now, if I look at the blood volume, or I go back to that blood volume, is there any specific number associated with that? Not really. It's very person dependent, okay? Physiologically dependent, because once again, we talked about it, different sized people have different amounts of blood, okay? So there's no kind of generalized answer for how much blood. There probably is, but I don't know it. For how much blood they're actually going to gain, just know that it's more than their normal, yeah.
So can hemophiliacs get pregnant then?
Can hemophiliacs get pregnant? Yeah.
They can?
Oh yeah.
Will they die, most likely?
Well, their body increases clotting factors, right? So that's already kind of fighting it. But then if they're known hemophiliacs, they're going to have way more care the whole time through their doctor. But yeah, hemophiliacs can get pregnant because that's how you spread it. They get it through women, right? It's a genetic disorder, comes from the X chromosome. Yeah. Good question. Okay. And then the GI tract will change, okay? Increased risks for some things. Gastroesophageal reflux, otherwise known as GERD. What is reflux? I'm sure you've all heard of it to some extent. Some of you have probably even had it. Acid reflux, does that sound familiar? What we also call acid reflux. Heartburn. Heartburn. They're going to start getting that heartburn reflex because think about it, that uterus, once again, displacing upward, putting pressure on the stomach, pushing the stomach up, so you're going to get more of those kind of fumes venting up. Okay, so they're going to get that heartburn potentially. And then the obvious ones, nausea, vomiting. Whenever you see a movie, immediately, that's how you know the woman's pregnant. She goes in the bathroom and pukes the next morning or whatever, right? Morning sickness, very common, but nausea, vomiting associated. And then anytime you have vomiting, you run the risk for aspiration. Aspiration, once again, is breathing something in that is not air. So if your airway's full of vomit, and you try to breathe and you breathe vomit, right, kind of makes sense. So anytime we got vomiting going on, aspiration is a risk, okay? And then weight gain. Weight gain during pregnancy is normal, okay? That is normal. Eating for two, essentially, okay? Trying to provide the sugar for perfusion for not only your body, which is going through a lot, right? The female body is going through a lot. It's changing, it's growing. The cells need that increased level of perfusion, okay? So there are some downsides to this. That weight gain can challenge the heart, right? We've got more blood, the heart's beating faster. Now we've got more tissue to perfuse, okay? And then there's going to be impacts on the musculoskeletal system. And we'll talk about that, I think, in a couple slides here in a little bit more specificity. But essentially, joints become looser or less stable. If we think about it, right? We want the child to come into the world fairly easily. We need looser joints for that to happen, okay? And then changes in their center of gravity, right? If now they're growing a baby, say they're growing a 10-pound baby, they're being pulled 10 pounds this way, right? But they're trying to adjust, but then they got loose joints, so they're at risk of falls. And then on top of that, they're heavier, right? So that excess weight can be pulling on them. That same patient who was telling me about that same student who was telling me about the 42 weeks things when she was telling me about her own pregnancies, she said she dislocated her hips a couple of times just because they were so loose. And if she fell down, she would probably end up dislocating something else again. One of them was a fall, one of them seemed fairly spontaneous. Okay, so it just happens. Understand there's going to be these changes are going to kind of compound on each other, make problems worse. Okay, so for complications, most pregnant women are healthy. Oh, any questions on any of this stuff, normal changes? Yeah.
What is the cause of like the cravings, like the super weird cravings? Like,
I don't know. I'm not sure. I don't know, because I'm curious too. Yeah, I'm not sure on what causes the cravings. Okay, so most pregnant women are healthy, okay? Remember another thing, people have been giving birth to babies for thousands and thousands of years, okay? Usually goes pretty smoothly. We're designed to do this process, okay? Now, that doesn't mean that they can't get ill or things can't be wrong, okay? So some may be ill when they conceive or become ill during pregnancy. Treatment's pretty easy for us. We're just gonna give them oxygen. Treat any heart or lung disease in a pregnant patient with oxygen. There is some advantages. I don't wanna say advantage, it feels like the wrong word, but there is kind of an advantage sometimes for the mother getting sick. For example, my sister had my niece back in December. She got COVID 2 weeks before my niece was born. Well, my sister was fine. She recovered just fine before the baby was born. But the nice thing is that my niece was born with COVID antibodies, has antibodies to the disease that her mother had. Okay, so there is kind of an advantage to that sometimes, but obviously the sicker you get, the more risk you run of other things going wrong. So, one of the big ones, diabetes, gestational diabetes, develops during pregnancy in many women who have not had it previously. Okay. Now, gestational diabetes usually resolves after delivery. Think about it for a moment. If they're not eating, if they're not increasing the amount of food they're bringing in, they're providing more sugar to the uterus, to the fetus, to their own body. It's not uncommon for that sugar level to start dropping because they're just not consuming enough sugar to feed all of the cells that need to be fed. Okay? And as far as our treatments go, nothing really changes. You're still going to give them oral glucose, still going to try and get them to eat a sandwich, see if we can get their blood sugar up. Okay? But as far as management goes, nothing really changes. Right? Any questions on gestational diabetes?
Is it more related to diabetes like 1 or 2, or is it
No.
completely-
So the question was, is it related to diabetes type 1 or type 2? No, not really. It's just because of the changes in their own body. That's why, yeah, they may not have had it at all previously. It just has to do with blood volume and sugar. So the next one, hypertensive disorders. So we start getting an insanely high blood pressure. Okay, so gestational hypertension. Well, we already know heart's working harder, right? 20% faster, and they have more blood. Okay, those two components right there just kind of make sense that blood pressure is going to change. It's going to increase. If you have more blood, you'd assume your pressure is going to go up. Because did the pipes change at all? Not really, right? Pump didn't change. okay? So that blood volume increase kind of sensically can start changing blood pressures. That said, we start getting concerned if it gets too high. Okay, so the presence of high blood pressure in the absence of other systemic effects. That is the only thing really going on. Once again, blood volume increasing, heart rate increasing, makes sense. Now a systolic blood pressure higher than 140 with a diastolic over 90, that's about where we're kind of toying that line, okay? I would expect them to be in that 130s systolic line, just because they have more blood, it makes sense, right? That kind of checks out for their normal to be changing. 140 over 90 is when we got to start paying attention to it. Now when we're talking severe is when we start getting higher than 160 systolic with 110 diastolic. That's where we're starting to get concerned. That is severe hypertension. Is there anything we can do for this? Anything we can do for hypertension? Nope. Nope. Not even in the medic scope is there anything we can do for hypertension. Okay? I mean, there is, but there isn't, right? We do have a med that drops blood pressures, but we can't use it for that, right? We only use nitro for MI-related issues. Okay, so we are not going to give nitro to correct this. It's outside your scope. Not more so, it's just outside of your protocol. It's not what it's for, okay? And then you'll come to find with medications, there's a scale, there's like class ranking. You might have even seen it on some of your meds. It's like D, C, B, A. And that's kind of the risk to reward of giving medications to a pregnant woman. Okay, so an example of when I saw that was a gal who had a kidney stone while pregnant, clearly in a lot of discomfort. And I told her, I can give you narcotics, but we're putting your baby at risk. And she said, then we're not giving me narcotics. And I said, okay, sounds good. Here's my EMT, have you met him? And so then he ran that call in. Also, on that same note, any woman 25 weeks or pregnant or greater, if you're taking them to the hospital, they do not go to the emergency room, they go to the labor and delivery department. Just on the off chance something's going on with the baby, it's gonna be premature. Pro tip. Make sure you're with somebody who has a badge to the doors. I got stuck between two sliding doors for about an hour at 3 in the morning after that kidney call. Because it's just like trying to flag people down as they're walking by, like, no, let me out of here. And it was a while. It was a long time, yeah.
You said 25 weeks.
25 weeks or greater, go straight to L&D, yeah. Yeah, now that might be, something you're not gonna see for your national or even your benchmarks here, but it's just something to note when you're out there. Okay, now gestational hypertension, obviously a problem, but it gets worse. There are things that we're more concerned about when it comes to high blood pressure in a pregnant woman, okay? Preeclampsia, so pregnancy-induced hypertension, okay? So there's gestational hypertension and then there's preeclampsia. This is gonna be one that they're gonna have labs drawn, they're gonna go to the doctor for their prenatal care, right? Their pre-baby care. They're going to have all that stuff drawn. They're going to start looking for preeclampsia. So can develop after the 20th week of gestation. Now our signs and symptoms: severe hypertension, severe or persistent headache, visual abnormalities, swelling in the hands and feet, and anxiety. Okay, so think about all the things that are going to happen as the blood pressure goes up. You guys have all had that headache where you just feel your pulse pounding in your brain, right? That headache's going to start showing up. Same thing if we're impacting the brain with discomfort, and our vision center being in the back of our brain, okay? That can be where we start running into the vision problems. And then swelling hands and feet, start getting that edema, okay? Starting to develop. And then anxiety, because a lot of things are going on. But it's preeclampsia. Preeclampsia is a warning sign, worse things to come. If we do not get it taken care of, they can go into full-blown eclampsia, which is characterized by seizures as a result of that hypertension. So they start seizing. So preeclampsia, they have a high blood pressure, they're anxious, headaches, all the things. They progress into eclampsia when they start seizing, okay? Now where this gets a little bit tricky is when I was talking about those medications, risk to reward. The medication we use to break seizures is not usually indicated. In fact, this protocol-wise is not indicated for eclampsia. We use a different one called magnesium sulfate, okay? Mag sulfate we use for a lot of things. Breathers is another one at the medic scope. But we do use it for pregnant women as well to help break these seizures if they have an eclamptic seizure, okay? So to treat them, lay the patient on their left side, specifically the left side. This is where we start running into that supine hypotension or hypotensive syndrome, right? They're laying flat on their back. There's 10 pounds mass sitting on their vena cava and aorta, less blood getting out, less blood returning, okay? So we want to put them on their left, take some of that pressure off of those vessels, okay? Maintain the airway, give oxygen as needed, suction if they're vomiting, rapid transport, and for you guys, call ALS. Get ALS to meet you en route if you're further away, further from the hospital than you want to be. Because once again, we can break seizures, we can break this seizure, it's just a little bit different, okay? This is unrelated to a lot of things, but I saw a post about the world's biggest baby being born the other day, or a few months back. 18 pounds. Yeah, it looked like a full-blown toddler coming out of that thing. Yeah. Give you a guess, it was probably a C-section, you know?
Here?
Or she's an animal in different respects. So, moving on. Transporting the patient on her left side can also prevent that supine hypotensive syndrome, like I was saying, which is that compression of the descending aorta and inferior vena cava by the uterus. Okay, if they're lying supine, think about the mass. It's going to lay down on those big vessels in there. We're crimping them off a little bit. Less blood leaving the heart or getting to the body, less blood returning to the heart to recirculate. Okay, so left side. For bleeding, internal bleeding may be a sign of an ectopic pregnancy. So this right here, pretty good diagram for an ectopic pregnancy. Okay, as that eventually grows bigger, that zygote grows bigger and bigger and bigger, pops that fallopian tube. This is now a bleeding risk. Okay, so an embryo develops outside the uterus, most often in the fallopian tube. That is going to be our ectopic pregnancy, and it can be anywhere in that fallopian tube. It can even be closer, towards this kind of entry area over here. Okay, but anywhere along that track, you can have an ectopic pregnancy. Okay, questions on ectopics at all? Do you think we're putting any pressure down to stop bleeding? We're not packing anything, right? This is when we're going to drive fast. Okay, if you get to a scope where you can give IVs, we might start reconstituting blood pressure with fluid. Okay. Now, consider an ectopic pregnancy in the presence of severe abdominal pain and vaginal bleeding during the first trimester. Extended beyond that, any woman of childbearing age who's complaining of abdominal pain, ectopic pregnancy is the first thing we're thinking. Okay? You're going to have to ask. You're going to have to just rule things out. You'll get comfortable with the question. Any chance you're pregnant? Yes, no. If yes, have you had this before? Right? We can start following up. Okay? But for sure, if we know they're pregnant in that first trimester, vaginal bleeding, pain, ectopic pregnancy is what we're thinking. Now, consider the possibility in a woman who has missed a menstrual cycle and complains of sudden severe pain in the lower abdomen. Right? Missing a menstrual cycle is going to be the big one. Now, hemorrhage from the vagina that occurs before labor begins can be serious. Okay? That's true. You can lose a lot of blood before and after childbirth, okay, as they're preparing. Now, especially if we're talking a lot of bleeding, it may be a sign of a spontaneous abortion. Spontaneous abortion, also commonly known as a miscarriage. Okay? I'll talk about what we're going to do with that after these next two. So, the big ones, abruptio placenta and placenta previa. Okay? Abruptio placenta, the placenta separates prematurely from the wall of the uterus. It's going to be ripping away. Okay? So, vaginal bleeding, let's say they're like their third trimester, we can obviously see that it's not an ectopic pregnancy because that baby's in there. Okay? If they have bleeding and pain, this is what you should start thinking, abruptio placenta. Okay? This is also one of my favorite medical words because it sounds like a Harry Potter spell. Like abruptio placenta, it would do some damage, that's all I'm saying. And then placenta previa. Placenta previa, that's what I was talking about, location of that placenta over the cervix. Okay, so placenta previa, the placenta develops over and covers the cervix. It's blocking the exit. Typically not painful, but does bleed. Okay, so abruptio placenta, bleeding, painful, premature separation. Okay, placenta previa covers the cervix. Now, I was talking to a student who took his national, this was last year, and he was saying he got a question on this. And of his answers, he had like abruption, abruptio, placenta. They had never had those two words put together. I don't know what the right answers they're looking for. Okay, just try to rationalize it and make sense with whatever they're phrasing it as. Okay, but abruptio placenta separates prematurely. And here's a picture. So the one on the left, that's going to be our abruptio placenta. So tearing away, we have bleeding, probably painful. The one on the right there is going to be that placenta previa, going to be bleeding, usually not painful because it's the baby's head just mushing down on that placenta. Okay. Now think about it though. If that placenta and that umbilical cord are the lifeline for that baby, this could be something that puts them at risk. So how do you think this baby is going to be delivered?
C-section.
What?
C-section.
C-section. Yeah. C-section more than likely. More than likely. Okay. Questions on vaginal bleeding with babies. Okay. So abortion. Passage of the fetus and placenta before 20 weeks. Okay. Otherwise known as a miscarriage. May be spontaneous or induced. Right? We can have miscarriages or they can go and induce an abortion at a clinic. Okay. Now the most serious complications of these, bleeding and infection, be ready for shock. Okay. Now probably not going to be septic shock. Think about how long that's going to take to develop. And obviously it could be, I guess, if we show up really late on somebody, like days late, but I'd argue we got bigger problems at that point. Okay. So if they're in shock, treat, transport promptly. Once again, transporting left side. Now, what do we do with this miscarriage? So there are times when people will have a miscarriage and there is a fetus that had developed. Okay, I've seen them, a couple of them before, like that big. Okay, they look like little aliens. You're taking it with you. You're going to put it in a red bio bag and you're taking it with you to the doctor. Reason being is that the doctor can go through and find what the cause of death was. If they find the cause of death, maybe if they get pregnant again, they can avoid it. Okay. I've seen this. This is one of the more heart-wrenching things. I have not personally had to deal with this one, thankfully. I do know some people that have, where they bring that aborted or that miscarried fetus with them, and mother just wants to hold the thing the whole time. They're going to let them. Okay. Try to make it make sense. And even to that extent, even if it's not a whole fetus, if there's any tissue or any limbs or anything, you're taking that with you. Okay. Best you can. All right, let's keep bringing the temperature down. Abuse. Pregnant women have an increased chance of being victims of domestic violence and abuse. Okay, this is where from time to time a vicious cycle is beginning when it comes to abuse. Abuse is cyclical. People who are abusers usually maintain and remain being abusers. Okay, now this abuse increases the chances of some things. Spontaneous abortion, right? There's impact to that abdomen. Could miscarry the baby. It can cause the baby to be born early, and usually babies who are born early are going to have a low birth weight. Okay, low birth weight can be premature or could just be a developmental thing. Okay, one thing that I've seen a couple of times when it comes to pregnant women is that, or not pregnant women, but people who are about to have their baby and they're in an abusive situation, they feel like they're stuck, right? Especially if they're not working, their spouse or significant other is the one who's providing all the money. They start getting into that mind frame of, well, where am I going to go? What can I do? I have no money. I have a kid on the way. This guy's the problem, but he's the one paying my bills. See why it becomes cyclical and it's hard to escape. Especially if you think about a child with an abuser, that person's probably going to try and be in their life. So you're probably going to be around them more often than not. Okay, so just keep that in mind. This does happen. Lots of stories of impact to that pregnant abdomen, as well as you've all heard the story like pushing them down the stairs and things like that. Okay, now the woman is at risk for bleeding, infection, and uterine rupture. We're dealing with a big hollow organ. That hollow organ has something in there that is taking up space, so there's going to be some tension on that uterus. Okay, so it can rupture. And then obviously infection and bleeding. If there's open wounds, we run the risk for infection, and bleeding is going to happen if you have a wound, okay, even internally. Pay attention to the environment for any signs of abuse. So bruises in multiple stages of healing. As the environment feels sketchy, there are needles everywhere, is there booze bottles everywhere, is it just kind of raising red flags in the back of your head? Okay. If you can, if we're worried about abuse, try to get them into a private area and away from the abuser if possible. Okay. If we can't prove abuse and the patient doesn't want to separate themselves from the abuser, there's not a lot we can do. Okay, but just do your best. Try to have an open and honest conversation with them because we can find resources to help them out. More so, the hospital is going to have a big, long range of resources. Okay, so just keep that in mind. That way when we take them there, we report it to the doctor, we do all the things we're supposed to do, we can get this woman out of a bad situation and then hopefully bring this child into a better one, okay? All right, switching gears. Never mind, substance abuse. We're moving into sadder. So, effects of addiction on the fetus. Premature birth, okay? Potentially a low birth weight, severe respiratory distress, maybe even death, okay? All of these can impact and kill the fetus, right? Potentially, depending on the substance. Now, fetal alcohol syndrome describes the conditions of infants born to a woman who has abused alcohol. Now, kind of as I don't know if it's an ease thing, but just because you had a glass of wine while pregnant does not mean you're going to give your baby fetal alcohol syndrome, okay? Even if you drink a little bit, doesn't mean you're going to give them fetal alcohol syndrome. You're not doing them any good as far as increasing risk, right? But that in its own right is not going to be what causes that. This is more so when people start living at like a 0.1 blood alcohol or higher, right? Where they're alcoholics, they're chronic users, they can't break that cycle. Those kids are usually born premature, low birth weight, and then definitely in respiratory distress. Okay, they come out their development is not where it should be because of the alcohol in the mother's system. Okay, so pay attention to your safety. Look for clues in what you're dealing with in the addicted patient. I've heard a story about there's a house back behind Engine 8 over there on Overland and Orchard, which we co-house with them. So I was talking with the fire guys and they were telling me, well, this house I've been in a few times, we referred to it as a bit of an opium den. A lot of users in there, a lot of IV drug users, fentanyl, heroin type stuff. I heard a story about a baby being delivered in there and it was not a great situation. Had to move a lot of things out of the way. Woman's crowning to the point, we ain't going anywhere, baby's coming. So they had to clear out a lot of space. Okay, so just make it safe for yourself. Make sure you're paying attention to your surroundings as best you can. And then have the understanding if we're dealing with a substance abuse patient, a substance abuse baby, they are more than likely going to need immediate resuscitation. Okay, just be prepared. Even if they come out alive, remember heart rate 60 or lower, we're starting CPR. Okay, so you might have to get involved a lot quicker. Questions, concerns on any of this? Okay. So, specialized considerations, trauma. With the trauma call involving a pregnant woman, we have two patients, the woman and the fetus. Okay, so keep that in mind. The stress level is going to go up with this. That is very normal. We're dealing with two lives in one go. Two birds, one stone. Okay, so trauma to a pregnant woman may have direct effect on the fetus depending on the impact. It's not uncommon for us to be called out. In my experience, it was a lot of police. They call us out. Pregnant woman didn't want us there in the first place. Police are like, we're kind of doing our due diligence. We show up. What's going on? Gotten a little fender bender. I'm fine. Baby's fine. Nothing feels weird. I kind of trust their judgment. They know their body better than I do. They know what it's like to have a baby inside them. I obviously have no idea what that's going to feel like. I trust their judgment, okay? That said, we're still doing our due diligence. We're still getting our vital signs. We're still doing an assessment. We're not missing things, okay? But you will be called out to these, sometimes unnecessarily. But if you think about the risk to reward, what's you showing up for 10 minutes and leaving, right? Especially if you're getting paid to be there. So, I kind of talked about earlier, they have that musculoskeletal changes. They get those looser joints. They have that weird center of gravity. That's increasing the risk of trauma, right? If you have loose joints and you fall down more often than you used to, that's a good way to get hurt, okay? So loosen joints and then increased weight plus that uterus displacement, okay? That's gonna disrupt their balance, fall over, all sorts of things, okay? Your center of gravity is being shifted from square in between your pelvis down to the floor to a little bit further in front of you, okay? So I've heard it described, like my sister, for example, was saying it felt like she was falling forward all the time. Just constantly being pulled in this direction just because of the weight. She's also, like 5'6", 100 pounds, so that probably made a difference too. But it's things to consider. Okay, so pregnant women have an increased amount of overall total blood volume and they have that increased heart rate. Okay, if they're bleeding, they're gonna lose more blood and they're probably gonna lose that blood faster. The heart rate's going up, they have more blood to lose, okay? So, shock is gonna be pretty quick. Okay, and then remember the fetus is still in there, maybe in trouble long before we see signs of shock. If they've lost enough blood and they're not perfusing that fetus very well, right, they might not reflect it in their own skin or their own physicality, but that fetus we're not gonna be able to see could be going under some problems. Okay, this is why we do the due diligence. This is why we double check things, make sure we're not missing stuff, especially because we know already shock is hard to identify, right? That was like the whole thing with shock. Just start treating for it early because it's tough to identify. Well, it's even harder to identify a fetus inside of somebody's body in shock. Okay, we can't see that one. When a pregnant woman is involved in a motor vehicle crash, hemorrhage may occur from injuries to the uterus. Remember, wearing their seatbelt improperly. It's supposed to go over those pelvic wings, those iliac crests there. If it's pulled up too high, it's on that uterus, on that pregnant belly. We run the risk of trauma, okay? With trauma being one of the leading causes of abruptio placenta. Okay, so common symptoms include vaginal bleeding and severe abdominal pain. Like I said, placenta previa, not typically painful. Abruptio placenta is. Think about it, it's tearing away from something. Okay, that tearing, ripping sensation, probably not pleasant, okay? Now, improper positioning of seatbelt, like I said, can result in injury to the pregnant woman and the fetus. So carefully assess pregnant woman's abdomen and chest for seatbelt marks, bruising, and obvious trauma. If we see those bruises, we see those abrasions where that seatbelt is, do you think that force was great enough to maybe impact the fetus? Exactly. Do your due diligence. You'd rather be wrong, take them to a hospital and be wrong, nothing's going on, than miss it, they lose a fetus or their own life, okay? Do your due diligence, especially in trauma. For cardiac arrest, things are kind of the same, right? We still have to deal with the mother. Fetus is not gonna survive without the mother anyway, at least potentially not, okay? Could still be viable depending on how far along she is and how close we are to a hospital. Could still do a C-section, that has happened, where they've pulled babies out of deceased women, essentially, okay? But when it comes to actual CPR, nothing really changes. You're gonna do CPR, you're gonna provide transport. The real big change, what do we do with the pregnant belly during CPR? You guys remember?
Lift it over.
What?
Lift it.
Yeah, we gotta displace it. We gotta move it over, right? So someone's job is gonna be to put their arms around that belly and not yank it, but a little tug towards you. Just shift it a little bit, okay? But understand, once this is your job, this is your job. You're probably not going anywhere, okay? And as EMT basics, I hate to break it to you, probably gonna be your job, okay? Other people with higher scope got bigger things to do. If you can help out that way, okay? And then make sure you definitely tell the receiving facility you're en route with a pregnant woman in cardiac arrest, because they're gonna prep L&D, they're gonna prep their ER docs, they're gonna make sure they have all the right people in that room, so when we show up, if we have ROSC, we can get the patient managed, the woman managed. If the woman is deceased, maybe we can save the baby. Okay, maybe the baby is still viable. Okay. So assessment management, our focus is on the woman, right? We have the fetus in there. That is a secondary thought, though. That is yes, we have to keep that in our mind, but we still have to treat the patient in front of us, okay? Like I said earlier, shock's hard to identify. So based on the mechanism, you can already start making some guesses as to what might be going on. How bad was the mechanism? Is this person gonna be in shock? Yes or no? Or is the likelihood of them being in shock high or low? Okay. Be prepared for vomiting and aspiration, and then attempt to determine the gestational age to assist you with determining the size of the fetus and position of the uterus. Okay, so gestational age, how long have they been cooking in there? How long have you been pregnant? Okay, or you can even ask what trimester you're in, right, if they're conscious. And then for these guidelines when treating a pregnant woman, open airway, high flow oxygen, ventilation, circulation, transport on her left side. Nothing's really changing, right? Outside of her being pregnant, not a lot changes as far as our management of these things go, except for maybe left side, okay, or displacing the uterus as needed. Kind of a random fact, but I think it's interesting. If you look at different countries versus our country, they kind of have a different priority set when it comes to babies and things like that. For example, Asian countries, they're very society forward versus here we're very capitalistic, personal success, okay? So here, baby dies, it's tragedy, it's heartbreaking, baby never got a chance to live. Sad, for sure. In Asia, they have a mixed viewpoint, or a flipped viewpoint. They're more upset usually when their elders die. Reason being, the elders lived a full life. There's life advice. There's so many things they can help us with. You can make a new baby in 9 months. So it's just kind of a change of perspective, okay? Just not like that's gonna make a huge role in your care or anything. I just think it's an interesting thing, right? If it kind of makes you look at our own society and how we treat people. I just think it's kind of interesting being in a society first society. Okay, moving on. Cultural values. So cultural sensitivity is important. Women of some cultures may have a value system that will affect their choices on how they care for themselves and then how they plan their childbirth process. Like I was saying, some refugees in this area, their birth plan is us, okay? On that same kind of note, there are some women who don't want male providers dealing with pregnant women. Some cultures, my experience, Middle Eastern, typically. They don't want the male providers working on their females. Which I also, once again, experienced that in labor and delivery. They're like, hey, you should go downstairs. There's a good live birth going on. I was like, sick. I go there, I knock on the door, no one answers. So I was like, hello? Because I know everyone's in there. And immediately the doctor looks at me and says, get out. And I was like, well, okay. So I left. Turns out there's a Middle Eastern couple. They were not, there's no males in that room. No males allowed in that room. That would have been good to know 5 minutes prior to me walking in that room, okay? But just keep that in mind. That is gonna be a difficulty you might have to run into, but also keep in mind that we're not gonna call a second unit because we don't know who's on the second unit. You might know, but you're not gonna know which one you're getting, okay? If you're a male, you're just gonna have to power through the moment, reassure them that you know what you're doing, okay? If you're a female, you just got looped into it, sorry about it. And then some cultures may not permit, like I was just saying, may not want a male healthcare provider to assess or examine a female patient. Try to respect those differences, try to honor the requests, but if it's a pressing issue and we're already here, we're dealing with it, okay? Teenage pregnancy, we're in America. We're really, really good at this. We got like 5 TV shows on it, right? Very, very good at teen pregnancy. One of the highest teen pregnancy rates in the world, United States. Okay, so pregnant teenagers may not know they are pregnant or may be in denial. Try to respect their privacy and try to get their history away from their parents. Kind of like what we talked about with the gynecologic lecture. They're probably not going to talk about their sexual history in front of their parents, okay? Now, obviously, they're pregnant. They're going to find out one way or the other. Either she's going to start showing or when the baby shows up 9 months later. Hard to hide that one, okay? Legally hide that one, okay? But there are people as well, I don't know if it really covers it in this lecture, I can't remember, that don't know they're pregnant. Like massively obese people, they might not know they're pregnant. My mom works at the clinic on, this was like 10 plus years ago, but one of their doctors ended up saving a baby, resuscitating a baby because patient came in, having abdominal pain, fairly large woman, had to go to the bathroom, birthed her baby right there in that toilet. Doctor came in and resuscitated her, or resuscitated it. I don't know, but I know the baby survived. I'm not sure about deficit stuff, but it does happen. People don't know they're pregnant, especially the females are gonna know this better than I do. Menstrual cycles are kind of temperamental. I've heard of people getting, too cardiovascularly fit as far as like runners, and then that pushes their menstrual cycle off. Like I knew a girl growing up, she only had a menstrual cycle once every 2 to 3 months, just because of her cardio fitness. She was running so much. On the same flip side of that coin, if they get too obese, it can start disrupting their menstrual cycles as well. So maybe they don't have them that often normally, so they're used to missing menstrual cycles, right? So they don't know. So just keep that in mind. And I'm filming, so I can't say all the things I want to say. So, childbirth, seldom an unexpected event, okay? There are occasions when it becomes an emergency, like I just told you. Toilet babies. People birthing their kids into toilets because they think they're not having a baby or they don't know they're pregnant, okay? But usually it's a pretty expected event. People know this is going to show up. It's not like you don't have a little while to prepare, okay? Okay, scene size up stuff. Not a lot of differences. The only thing, if time allows, a gown should also be used. You will put on all of the things, okay? If time allows. That said, there's usually no good justification to not prevent infection during childbirth, okay? Yeah, consider additional resources. So I have delivered a baby. I'll talk about this later. I was the second unit on that call, okay? So I was the additional resource. We just happened to be at breakfast with this crew. They get dispatched out to impending birth. I was the only student, and my preceptor said, can we come? And the medic on the other crew said, absolutely. I was fortunate enough to get there. I'll tell more of that story in a little bit, but I was a second unit, so be prepared to call a second unit. That way, if things go sideways, we have multiple hands ready to help out, okay? Because remember, once that baby's born, how many patients do we have? We have 2 patients now. Someone's got to manage the baby, someone's got to manage the mother, and someone's got to drive, right? So we got to kind of make things work for ourselves. Spinal mobilization, that kind of stuff. Primary assessment, try and get as much info as you can. The big one, which I'll get to, is history, okay? So for transport decision, if delivery is imminent, be prepared to deliver on the scene or at the scene. When I'm saying imminent delivery, I mean that baby is crowning. You're seeing that baby's head in the vaginal opening there, okay? You're probably not going anywhere. You're gonna hang out, you're gonna deliver right where you are. The ideal place to deliver, either in the ambulance or in the woman's home. And then if delivery is not imminent, that's when we can transport, okay? Another thing on this note, however mother wants to deliver is how she's gonna deliver, okay? If she wants to, and I've heard this happening, if she wants to stand in a doorway and do this while delivering her baby, guess where you're at, right? Watch your face. And you'll see why I say that in a moment. But yeah, right? However mother wants to deliver is how she's gonna deliver. That said, we have some preferences. We'd rather do this in the ambulance or get you in a situation you're comfortable in, like your own bed type stuff or on the couch. I have seen one lady birth in her bed, and I can just tell you I would never sleep in that bed comfortably ever again. Never, ever, ever. It's a beautiful thing. Apparently, on my end, it was not as pretty as they said. So rapid transport for pregnant patients who have significant bleeding and pain, hypertension, seizures, right? What are we worried about with the seizures? Eclampsia, right? So that's what we're worried about. Even the hypertension, that could be pre-eclampsia. Maybe we're building that blood pressure high enough to the point they could start seizing. And then if they have an altered mental status, that could also be a reason for rapid transport. Now, history is gonna be huge when it comes to babies, okay? What is your expected due date? When did you get pregnant? How long have you been pregnant? When is this baby expected to be here? Okay? Are there any complications that I need to be aware of or that you're aware of? Is the baby in a weird position? Do they have the cord around their neck? Is there something going on that you're aware of that we don't know? Have you received any prenatal care? Prenatal, gone to the doctor as you're pregnant, taking the vitamins, doing all the things you need to do to be prepared for that delivery. And then a full medical history, obviously, as best you can. What are their disorders? What are their conditions? Maybe we ask, are you hemophiliac, right? That could play a role. If you're gonna bleed while they're delivering, that's something we gotta know about, okay? So pertinent history should include questions related about specifically to that prenatal care. So get your due date, frequency of contractions, history of previous pregnancies, deliveries, possibility of multiples, and have they taken any drugs or meds? Is the water broken? And if was there a greenish color or weird smell coming off of it? What that green color is called meconium. Okay, this word right here, meconium. Meconium usually shows up in post-term babies. So babies who are in the uterus and getting the womb service, if you will, longer than their 9 months, okay? Because think about it, that baby's growing and developing, their GI system develops. Meconium is baby poop, okay? They're in that amniotic sac, they're pooping. Well, if we think about airway, right? There's just poop floating around in a little fluid-filled sac that they live in, get in their nose, get in their mouth. Okay, that could be an aspiration or an airway risk. 2 things I'm going to talk about, one a little bit deeper, well, 3 things. So frequency of contractions, pregnancies, deliveries, and possibility of multiples. I'll get into the contraction one later, but possibility of multiples, hold on to that idea. Okay, reason being is that there's one time in particular I'm going to talk about where we want to know because we could do some serious damage, maybe even kill a baby if we're wrong. Okay, yeah.
Slow down just a little bit.
Yeah.
You're just kind of ripping around.
I know, I'm sorry. Yeah. So with multiples, do I need to go into that again?
No. Just,
okay.
Just
generally.
Overall, yeah.
General. For sure, I can do that. So previous pregnancies and deliveries. So we have kind of a scale that we use. I told some of you guys this story. I'm going to tell it again. So when we're talking about how many, previous pregnancies and deliveries, we use kind of 3 different words. Okay, we use paragravida abortion. So para, P-A-R-A, there's gravida, G-R-A-V-I-D-A, and then abortion is abortion. I'm not gonna spell the whole thing out, okay? So, paragravida abortion. Para, or rather, let me rephrase, gravida. Gravida is referring to how many times have you been pregnant, okay, total. Yeah, how many total times you've been pregnant. Now from there, we're gonna get some answers. I've been pregnant 3 times. Okay, the next question, how many times have you been made a parent for para? How many times have you been made a parent? How many times did that baby was delivered, came to fruition, is a child now, okay? Well, let's say I've been pregnant 3 times. How many of them became, have you actually birthed? 1 of them. So then we already know they've lost 2. So abortion is how many of these pregnancies did not come to fruition, okay? Now I caution you to be better than my wife is. She put her foot in her mouth aggressively last year with the same thing. So there is a thing in pregnancy called Braxton Hicks contractions. They're premature contractions of the uterus, basically saying we're ready to have a baby, but this is at like 22 weeks, 23 weeks, okay? They're false contractions. She's dispatched out to abdominal pain at a clinic. When she gets there, the doc says, oh, I think she's having Braxton Hicks contractions. This woman was 15 weeks pregnant. So she's not even at the point for Braxton Hicks. It's too early. So my wife, bless her soul, said, well, how many times have you been pregnant? She's like, I've been pregnant 9 times. She's like, oh. And this is the exact words my wife said, you're kind of a pro at this. And then that's when the lady said, yeah, only 2 of them have survived. Oh, really, really uncomfortable. To which point the next words my wife said were, hospital? And they left. Yeah, you're gonna put your foot in your mouth from time to time, okay? Just keep that in mind. It does happen, but you gotta ask. I would just maybe let them finish their sentence before you interject with, you're kind of a pro at this, huh? Because that's how you get in trouble, okay? Secondary, not a lot of changes, okay? One thing we can do is assess for fetal movement. Now for us, we don't really know what we're doing when we're trying to feel for it. Trust the mom, okay? Does she feel any movement? Obviously it's inside of her abdomen. She's gonna know, okay? If the patient's in labor, focus on the contractions, be ready for delivery. And if we suspect delivery is imminent, check for crowning. Anytime you are dispatched out to imminent birth, you're gonna check. Gotta make sure, okay? I got a couple stories on that as well, but I'll get into it later. And vital signs, managing that, right? But we're more aware of like their blood pressure. We know they're gonna be tachycardic more than likely because they have that increase in heart rate by about 20%. We're gonna expect higher blood pressure with that increased blood volume, but we wanna make sure it's not getting too high because then we start running that risk of preeclampsia to eclampsia when they start seizing. And then one other vital sign I didn't mention, it's not up there. What's the last one? We kind of talked about the condition first.
Their breathing.
Not their breathing. What is what?
Hypertension or blood pressure?
Not blood glucose is what I was looking for. Not hypertension, blood glucose, because remember, gestational diabetes, also present, or potentially present, okay? Reassess. Just remember you're gonna have to do 5-15. Also keep in mind we've got 2 patients if you're delivering on scene, so you're gonna have to reassess both as needed, okay? Make sure you notify them that you're coming in with a baby as well. They're gonna be really pissed off if you show up with a brand fresh baby and say, this is for you. And they say, why didn't you tell us? Be like, I forgot. They're gonna yell at you, I promise. They're not gonna be happy with you. So make sure you let them know, okay? For a pregnant patient with a complaint unrelated to childbirth, be sure to include the pregnancy status in your radio report. So on that same story I told you, that gal with kidney stones who was pregnant, I had to include she is pregnant. I don't think it's a pregnancy-related problem though, okay? Make sure they know. And then you're gonna write 2 charts. You got 2 patients now. If you birth a baby, you got 2 patients, 2 charts. The baby that I birthed, the medic whose call it was supposed to be, I was an intern, so I didn't write charts anyway. The medic whose call it was supposed to be didn't realize he had to write 2 charts until we bumped into him at 5 in the morning at the hospital and said, "Did you get both your charts done?" And he's like, "What do you mean both? Like for the baby?" He's like, "Shoot." He didn't say shoot. And he worked his way through, right, and had to go back and do another chart. So keep that in mind. You're gonna have 2 charts. Okay, getting into childbirth stages of labor. Let's take a break before we get into this. Let's take a good 10-minute breather, come back 9:35. Back to babies, huh? So let's, so stages of labor. Okay, so first stage of labor, when we're starting, the baby is showing up. The end of that, or rather, we're worried about the dilation of the cervix. Okay, so stage 1, cervix dilation is gonna be the big one. Okay, stage 2, that's when we have our actual fetus delivery. Okay, the baby comes out. But remember, baby's out, we still got a placenta in there. Okay, so stage 3, delivery of the placenta. Okay, so stage 1, cervix dilates, makes room for baby. Stage 2, baby goes through, delivers. Stage 3, placenta follows the baby. Okay, so first stage begins with the onset of contractions and ends when the cervix is fully dilated. We're looking for 10 centimeters. Okay, so contractions begin, cervix dilates. Now this is usually the longest stage, lasting on average 16 hours. Okay, if this is their first pregnancy, this is a long stage. Okay, they're going to be in labor for a while. There was one of my imminent delivery calls was dispatched out to the airport. Flight coming from, or was diverting from Atlanta to Seattle, diverting to here. Gal was on there, said baby's crowning, flight's 20 minutes away. It's like, well, this is just a nightmare. So I had enough time to sit in that airport or in the tarmac there. I don't want to do this. That's all I had time to think about. So I don't want to do this. Here we are. So as we show up, or as the plane lands, they put the little staircase next to the door. I start walking towards it. As Boise Fire had gone in, they beat me in. As I'm walking up, they're walking out. I was like, what's going on? They're like, oh, she's crowning. It's like, well, where are we going, guys? Because the party's that way. They continue to walk away. It's like, okay. So I went up and I went in there. Same thing. Fire guy right there is pushing the patient in a wheelchair. And I was like, what's going on? Oh, she's crowning. Okay. I look, she's not crowning. Okay. So we get her in the back of the ambulance. We are going to take, she's obviously not from around here. She's from Atlanta, going to Seattle. I give her the whole spiel, you know, listen, you're pregnant. Sounds like you're having contractions. If we have to, we'll stop. We'll deliver this baby. And I will never forget her exact words. Fuck that. I'm not delivering this baby in an ambulance. And I said exact words. We're on the same page. Let's go. And so we ended up driving real fast to St. Al's. Then found out later she was in labor for a solid 26 hours. So yeah, I didn't need to drive fast, right? In hindsight, it's like, well, didn't need to get there that quick. She was fine, but we just didn't know. Okay, so typically the longer, or their first pregnancy is gonna be their longest contraction, or excuse me, longest labor set. Now, uterine contractions are gonna become more regular and last about 30 to 60 seconds each. So the frequency and intensity increases. So how frequently they're happening and how strong they are, that's gonna start increasing. Okay, now you have a couple of options because we're gonna have to pay attention to that, right? If we know, okay, this is forceful, this is fast, we know this baby is gonna show up here soon. Couple of options to check. One is more reliable than the other, but it's sacrificing someone else's hand. So first one, I used to ask the patient, let me know if you're having a contraction, let me know when it starts, and then let me know when it stops. And then after when it stops, we'll get you back into breathing. I'll ask you, intensity level 1 to 10, what was that at? Well, come to find, people in labor don't really want to talk a whole lot when they're having contractions. Who would have thought? So I learned from that mistake. The second time, I said, this is my EMT Adam. If you're having contractions, squeeze his hand. When you're done having a contraction, let go of his hand. Poor Adam. He walked away with a crumpled up hand after that 10-minute, but I was very accurate with how long my contractions or the contractions were going on. Okay, so that's one way or a couple ways that you can register it. Do your best either way. Just saying, make sure you're working with someone you like or maybe don't like if you're going to sacrifice their hand. Okay. Now to kind of illustrate the labor length thing. I will tell you the story now of when I delivered the baby. So we were at Luke's downtown eating breakfast with another crew. I was medic 1-7 in the north end. They were medic 1-3 over off Broadway in Linden. Eating breakfast, they got dispatched out, kind of like I told you. It's like, can we go? And they said, yeah. So we show up, I get out of the ambulance, and I start walking up the driveway, and out comes toddling this. This is for the story. She is an African refugee. You'll see why it's harder in a second. So they're always like, what's going on? And the fire captain's like, we gotta go. Which usually if they're saying it like right now, something's going wrong. So I look, sure enough, there's the baby's head. It's like, okay. So we get into the back of the ambulance and I was like, nah, let's just go. We have less than a 5-minute drive, fast as you can get us there. Well, during that 5-minute drive, we pulled over a minute later, delivered this baby. Now, for reference, this patient was 19 years old. This was her 3rd child. My preceptor, I'm a student at this time, so I'm on the side. My preceptor is at the foot, and he's like, okay, you're catching this baby. And I was like, I don't want to do that. And he's like, that sucks. You're catching this baby. So I was like, cool. So we start swapping spots. As we swap spots, she yells, and we look, and both of us had enough time to get a hand on either side before that baby hit our hands, okay? So 3rd kid shot out almost immediately, okay? Now, what made this tougher, she only spoke Swahili. Can't fiddle your way through that one. There's no Google translating that one, right? So it was kind of an awkward interaction. She didn't know what we wanted to do with the baby. We were trying to give it to her, put skin to skin, but then even that was a little bit weird. She seemed very disinterested in the child, but everything was fine that I knew of. Fast forward, that was 2019. 2021, cleared medic, working my life away, working that 1-3 off Broadway. It's not my call. We get dispatched to imminent delivery. I'm cackling the whole time because it's my older partner and it's one of my former FTOs. So me and him got a good rapport with each other. I'm just laughing at him the whole time. He's like, you're only laughing because you don't got to do this. And I'm like, yeah, you're right, absolutely. So we pull up and I'm like, boy, this driveway looks familiar. Out comes toddling a little 2-year-old black girl. It's like, there's no way. Sure enough, same lady. She ended up delivering 2 minutes after we got to the hospital the second time. Okay, so it can be really, really quick. Also, funny story about when that baby was born, it was a little girl. My preceptor misgendered that baby for like the first 15 minutes of its life. He's like, well, I just saw a thing hanging there. It's like, you thought the umbilical cord? What kind of baby you think this is, dude? But, you know, we all make mistakes, I'll just say that. So, like I was saying, so the first one, it's gonna take a little bit of time to build up. Multiple kids, if they've had multiple in the past, they're going to be coming pretty quick. So that's why that paragravida conversation is so important, right? Because we want to know how quickly do we need to be involved, because the more babies they've had, the quicker that baby's going to come out, okay? Now, back to first stage of labor. Why, okay, that's stupid. Okay, so labor, like I was saying, generally longer in a primigravida. Primigravida, first pregnancy. Obviously, then the multigravida, they've had multiple pregnancies. And then a woman may experience preterm or false labor. Those are those Braxton Hicks contractions, okay? So they're earlier contractions than what they should normally be, or they're earlier than they should normally be, okay? But they're premature. That baby is not done cooking yet. The middle's still soft, like when you're making brownies, okay? Yeah, Sam?
Is there a certain point in the trimester when that starts happening, like 25 weeks for Braxton Hicks?
They say around 20 to 25 weeks is usually the onset of them. But that's where it's like, oh, we're still too early because 40 is considered normal, right? Good question. Yeah, so for the YouTube folks, Braxton Hicks usually starts around 20 to 25 weeks. Here's a table. You guys can look at it of your own accord. So, moving on. Some women experience a premature rupture of the amniotic sac. Okay, that's that typical, my water broke, but not everybody's gonna have that, okay? Also understand, when their water breaks, they may or may not go into labor immediately after that, okay? Sometimes it can rupture prematurely. And then provide supportive care if it ruptures and we don't have a baby coming out yet. Or just supportive care, transporting, okay? Now, we don't wanna overstress this mother. So if it's something where the water broke but we don't see crowning, Maybe we're not lights and sirens, but maybe we're just changing the street lights on the way there. Okay, let's keep the stress levels as low as we can and still get there at appropriate times, but then also have the understanding if you have to, you're gonna pull over, you're gonna deliver that baby. To the extent delivering children is the BLS or in the BLS scope. And you're gonna have medics who are gonna say, you ready to deliver this baby? And you're gonna say no, and they're gonna say, that sucks, here you are. Okay, so it is in the basic scope. Now, I will also say no medic worth their salt is gonna leave that to you, just because there's other things we gotta look at. There's meds we can push if we have to. If mother's bleeding, we can get involved on the cardiac arrest side a lot deeper. So where I guess I'm going with this is, if you have a medic who's really pushing that you're delivering, make sure they're at least there with you, okay? Because if something goes wrong, that's their head too, okay? Now, also during the first stage, the head of the fetus descends into the woman's pelvis as it positions for delivery. This descent is called the lightening. What the hell is going on? Sorry, I'm getting random texts from people I don't know about really technical things that I don't understand. It's kind of weird. But yeah, so when that baby starts to descend down, we get that head into the birthing position, that's the lightening, okay? So first stage starts with contractions, ends with cervix dilation. Once again, 10 centimeters cervix dilation, or 10 is what we're shooting for anyway. The second stage, so this starts when the fetus encounters the birth canal, and it ends when the baby is born. Okay, so at this point, those uterine contractions are going to get closer together. They're going to be lasting longer. Their intensity is going to go up. Okay, that baby is, the body is prepping to push that baby out. Okay, and then this is where the perineum. So this is one of the only times, if not the only time, you're going to have to keep a constant view of the perineum. Okay, reason being, if it starts to bulge significantly, that's the top of the baby's head. That is crowning. Okay, if you want to know what it looks like, dang it, I thought it was gonna be really cool that picture would be next, it's not. There's a picture of it, it's coming up, okay? So, but the perineum will bulge significantly, you'll see it, okay? It's gonna look pretty abnormal. Our third stage begins with the birth of the newborn, and it ends with the birth of the placenta, or delivery of the placenta, okay? That placenta has to completely separate from that uterine wall in order to be delivered, and this can take up to 30 minutes, okay? So just understand, once the baby's out, we're still not done, okay? We still have to manage, we still have to be ready for that placenta to show up, but it may take a little bit of time, okay? Okay, so preparing for the delivery. Consider delivery at the scene when the delivery is imminent, meaning they're crowning. We've only got a few minutes before this baby shows up into this world, okay? If they are crowning, we're staying, we're delivering this baby right where we are, okay? A natural disaster, inclement weather, other environmental factors can influence your ability to get to the hospital. I know one medic who, granted, backstory on this guy a little bit, his head's pretty far up one of his own orifices. I'm surprised he can even breathe. So I don't believe half of his stories, but there's still something to glean from it. So he told me a story, he used to work in Reno, and he had a set of twins delivered, but it was during a blizzard in Reno. So it ended up taking him 3 hours to get to the hospital after leaving the scene, when normally took all of 20 to 30 minutes. Okay, so just understand environmental factors are gonna delay and disrupt this process. You still have patients to take care of, you still have to manage them, even once the baby's out. Obviously, perfect world, we're at the hospital and we don't have to deal with it, but here we are, okay? So to determine if they're imminent, ask the patient, how long you've been pregnant? We're looking for about 40 weeks or so, 40, 42. When are you due? That's gonna be a kind of a telling thing. Well, my due date is April 3rd. Well, that's today, right? So we're ready for it. Is this your first baby? How quick is this delivery gonna go, right? That's what we're asking for. If you're having contractions, how far apart are they? How long are they lasting, okay? If you can, start counting at that point if you can see them. And you're gonna know a woman's having contractions because she's gonna be pretty uncomfortable and probably gonna make a sound, okay? Like a grunting discomfort sound, okay? So just keep that in mind. Pay attention to the details so that you can start figuring things out. Have you had any spotting or bleeding? Has your water broken? Do you feel as though you need to have a bowel movement, or do you feel like you need to push? Both of those questions are asking about how imminent is this delivery. Because if we have a woman who's saying, I feel like I need to use the restroom, I need to have a bowel movement, that's not the end that's coming out of, okay? We're more worried about baby delivery than we are about stool. Because fun fact, women tend to poop while they're delivering babies. That happens. Think about pushing and pressure and bearing down, it kind of makes sense, okay? Were any of your babies by C-section? Is this something that's happened before? Remember, if it's happened before, it can happen again, okay? Have you had problems with any of your previous pregnancies? Drugs, alcohol, meds? Chance for multiples? Once again, pay attention to multiples. That'll play a role here in a second. And then does your physician expect complications? Hopefully they've been getting good prenatal care, so we can kind of see, or they'll kind of know if something's going on. If the doctor's expecting problems, maybe we ask them and we get prepared for the same problems, or as close as we can, okay? If the patient says she's about to deliver, she has to move her bowels, or feels the need to push, you should prepare for delivery. You're gonna have to visually inspect the vagina, check for crowning. Don't touch the vaginal area unless delivery is imminent. You're gonna have to look, but we don't have to touch anything until that delivery is going, okay? This is another one of those CYA things. Make sure you're protecting yourself, right? This is kind of a legal gray area. You can get yourself in some trouble inappropriately touching people, okay? If they're delivering a baby, they're not gonna care a whole lot, okay? Because obviously we need to be down there. But if they're not delivering in that moment, don't touch them, okay? Now, once labor has begun, it cannot be slowed or stopped, okay? Never attempt to hold the patient's legs together, and do not let them go to the bathroom, okay? That's how bad stuff happens. I know one medic, or rather, let me rephrase, my first EMT teacher, one of them, I had 3, Chris being one of them, 3 teachers in one class, not 3 classes, I'm not that dumb. She had a partner, she worked 911 in Nashville back in the day, and she had a partner who would keep a crisp, clean $100 bill in his wallet at all times in case of deliveries. His technique was, if you don't deliver my ambulance, I will give you this $100 bill. And it worked half the time. But then immediately after they got to the hospital, we went straight to the bank and got another $100 bill, okay? But I don't endorse that. I would not do that, okay? Because it's kind of a gray area, once again, maybe get yourself in trouble, okay? And then remember, if you deliver at the scene, you're only assisting the woman with the delivery. She's gonna do the heavy lifting, she's gonna have to. Our job is just to help, okay? Make sure we're getting it figured out. So your emergency vehicle should always be equipped with an OB kit. You will have an OB kit. That's another part of that my childbirth story that was a little difficult. When we were in 1-3's ambulance, or no, we were in our ambulance, but we had an old rig. So the stuff wasn't where it normally was, couldn't find our OB kit. So we had to pull over, had someone run out, grab the other ambulance's OB kit, run in. Turns out it was underneath the seat instead of up in the cabinet where it should have been. But that was another complication, right? Things are moving fast and we don't have the things we need. So inside of these kits, you're gonna have a few different things. Okay, sterile gloves being one of them. Sterile gloves meaning that we can't touch the outsides. Okay, so putting those gloves on, you're grabbing the inside, sliding your hand through. Once this hand is sterile, then we can handle the other sterile glove and put the other glove on without touching the outsides. Okay, think about infection, think about open source of infection. We're gonna be right in there, okay? Make sure you're wearing your sterile gloves. I would heavily recommend wearing a gown. I did not wear a gown and I got stuff on me and I'll never forget that, okay? So wear your gowns, trust me. It'll also come with clamps. So we gotta clamp that umbilical cord. It'll come with a scalpel to cut the umbilical cord. It also has one of those suction bulbs. We kind of talked about it like last time, I think. Right, you put it up their nose and you suction stuff out. It'll come with one of those. It will also come with a hat, little baby hat to put on them. Remember, kids lose temperature quick. They don't have a lot of fat tissue. They haven't built their insulation up yet. And then underneath, you can't really see it, but this kind of square that it's resting on underneath, that looks like what we use it's called a trans warmer. So remember, once again, keep baby warm. Now our hot packs, you do carry hot packs in your ambulance. They're too hot. They get you like 120 degrees, you'll burn the skin on that baby. These trans warmers, they're kind of a big gel pad. They have a kind of a felt side and then just a clear plastic on the other. And there's a little coin inside of there. Once you break that coin inside, it creates a chemical reaction, heats up that pad, but it doesn't get hot enough to burn the baby. In fact, you can put it on your skin. It feels pretty good when it's cold. but that's what we're gonna use, help keep that baby warm, okay? So for patient positioning, try to preserve their privacy, okay? On a firm surface padded with blankets, sheets, and towels, okay? Elevate the hips about 2 to 4 inches, support the head, neck, and upper back, and then have her keep her legs and hips flexed with her feet flat and her knees spread apart. One other way that I heard this described, I think the women will understand where I'm coming from with this one. I've heard people say, imagine you're in stirrups at the OB, okay? For the guys, women have to put their legs up in stirrups when they go to the OB clinic. Okay, so kind of a similar approach, similar setup there. So a couple things when it comes to prepping the space. Okay, our gurney is okay for it. That's not a bad spot. What I will say is when we're setting her up, everyone see me okay if I go over here? Cool. So what I will say when we're setting her up, we do not want her hips being here. Okay, as if that baby comes out, there's a lot of floor underneath here, and they are some slippery little footballs, okay? So when we're delivering, like we did with mine, we backed her up so that when that baby came out, we ended up catching the head right about here, okay? So make sure you're just prepping a space so that if for one weird reason or another, you're unable to fully catch the baby, it's not gonna hit the floor, it's gonna go a couple of inches down to the gurney cot, or to the gurney pad, okay? Now, place towels or sheets on the floor around the delivery area. There's gonna be a lot of fluid coming out, blood, amniotic fluid potentially. It's gonna get slippery. So make sure we're not slipping ourselves, that way not slipping with people's brand new babies, okay? Open your OB kit carefully, put on sterile gloves, and then use the sterile sheet and drapes from the OB kit to make a sterile delivery field. Basically, you guys know what Chuck's pads are? Those blue pads you put underneath, like something similar is like people who put those pads on the floor and then their dog pees on the pad, and it's a similar idea. You will have one of those in there as well. You're gonna have her lift her hips and just place that underneath. That's also sterile. The OB kit is one of the few sterile things we have. There's no germs on there, okay? Because we don't want to spread infection because we are obviously around the infection source. So this is the delivering position. This is crowning, okay? It's pretty obvious. You're gonna notice it pretty darn quick, okay? Any questions so far? Okay. Now, if I was a better teacher, I'd horrify you guys with a live birth video. I just personally don't wanna go find one because I don't wanna look at it if I don't have to. So I don't have that. If you want, Google on your own. I'm sure there's plenty out there, okay? Okay, so for delivery, I'll go through it, and then at some point I'm probably gonna stop and I'll just show you the motions, and then we'll go back to the lecture again. So, your partner should be at the patient's head to comfort, soothe, and reassure. I also think this is not a bad spot for a dad to be, potentially, right? Have someone who's involved. If the patient will allow it, put on oxygen. Continually check for crowning. Some patients may have that precipitous labor and birth. It's very fast, okay? And then position yourself so that you can see the perineum at all times. You are going to stay near the foot of the bed. Did you look up a birthing video?
No, it's in the book.
Oh.
That's crazy.
It's beautiful.
I want to do it.
Okay, so timing the patient's contractions. So remind the patient take quick, short breaths during each contraction, but not to strain. A lot of mothers are gonna take some like Lamaze classes, some sort of classes to help them with like their breathing techniques. They're gonna be familiar. Our job is to kind of remind them of that, okay? Short breaths during their contractions. Once they're done with the contraction, take your big breaths, relax a little bit, try to get big breaths in through your mouth or through the patient's mouth, okay? That way she can kind of recirculate, reperfuse, chill out for a second because the next wave is coming. Okay, so when it comes to actual delivery, we are not pulling on anything ever, okay? This is not an aggressive action by us at all, okay? We are just guiding this baby out. So, hands underneath. Once again, not uncommon for women to poop while they're delivering a baby, so maybe watch your hand placement. You don't want to grab a fistful of the wrong warm thing, okay? So, as the baby's head's coming out, you're just supporting it. As it's moving towards the shoulders, the head to the neck is out. it'll slowly rotate as well. That's kind of how, when they're delivering, they come out face down and then they rotate to kind of a sideways. So as it's rotating, still supporting the head, we're gonna go down and then up. Down is delivering the top shoulder. Once that top shoulder is out, we lift up, we get the bottom shoulder out. And then usually from there, we're just supporting as it slides out, because once the shoulders are out, the hips should come out just fine. Okay, now that's perfect world. That is how most of them go, okay? Not every one of them is gonna go that way, and we'll talk about weird positions here in a second. So, delivering the head, observe the head as it exits the vagina, support the head with your gloved hand as it rotates. So once again, we're not pulling, we're not pushing, we're not doing any of that. It is all the work is being done for us. We're essentially just coaching the baby into the world, okay? So, delivering the head. Apply gentle pressure across the perineum with sterile gauze pad to reduce the risk of tearing. So if you put your thumb on that perineal area and just put some pressure, you significantly reduce the risk of them tearing, which they'll be thankful for, and it's also less blood for us to deal with. Okay. Be prepared for the possibility of a bowel movement. Once again, watch your hands. I love this last bullet. Do not poke your fingers into their eyes or fontanelles. Okay. Don't go blinding brand new babies. It's not a good look. Okay. But their fontanelles, right top and the back, they have two really big soft spots. Be really conscious of them, because those are sections where the skull is not fused. So that's their brain. If you push too hard, you're pushing into their brain. Okay. So, any questions so far? Alrighty. Fix your face. Fix your face. So, that's the same thing I told my wife when she watched the baby be born. She's like, oh, fix your face. I can't. So, for that unruptured amniotic sac, like I said, fairly rare. Does happen though, 1 in like 80,000 or so. If the amniotic sac does not rupture by the time the head is crowning, it will appear as a fluid-filled sac emerging from the vagina. Okay. Now, it will suffocate the fetus if not removed. Remember, we're taking them from an environment where they don't need air to an environment where they do need air. So if they're covered in that sac full of amniotic fluid and they take a breath, they're not breathing air, okay? And then you may puncture the sac with a clamp or tear it by twisting it between your fingers, okay? So a couple of different ways we can do that. And then when it comes to suctioning the baby's airway, mouth and nose immediately. Historically, or I guess stereotypically, when you think a baby is delivered, what's the first sound you're going to hear from them? A loud cry. Does a cry come out of your nose or your mouth? Your mouth, right? So which one do you think we need to suction first? Their mouth, right? Because they're going to take that, blah, right? They're going to take that big deep breath before they start crying. So make sure we clear that mouth out. Mouth, and then each nostril, and you'll have that little suction bulb, okay? Now, for the umbilical cord around the neck. As soon as the head is delivered, use one finger to feel whether the umbilical cord is wrapped around the neck. We also call this a nuchal cord, N-U-C-H-A-L, a nuchal cord. Now, usually, we can slip that cord gently over the delivered head. If not, we have to cut it. Now, once the cord's cut, we got to get delivery going, because their lifeline to mom has been cut. We got to get them moving. Where is this going to be kind of problematic if we have to cut a cord? Remember what I've been telling you guys to hold on in your mind the whole time? Multiples. What if we have a cord around a baby's neck, but they have twins in there? Do you know which cord you're cutting? Right. That's why the idea of multiples is so important. Because if we have a nuchal cord, and we have to cut that cord, we don't want to cut, the sibling's cord, because then we just killed the baby in the womb potentially. Okay, so that's why it's really, really important to ask about multiples, so that we can make sure if we see certain things, we can deal with them, or kind of know what our next kind of path is going to look like. Yeah, Sam?
So what do you do in that situation?
Hopefully you're going to slip it over their head. Hopefully. If not, I would definitely, if I saw a nuchal cord, or like, if I knew they had twins and I was worried about a nuchal cord, I would have medical control. Basically, all I got to do is hit call. So I can call them like right now. Hey, we got a nuchal cord with multiples, not sure which one, what do you want me to do? Okay, so just rely on medical control, but be ready. This is one where that little bit of planning goes a long way. Okay, the planning is priceless, but the plan is worthless. Have plan B and C also in place, okay? Because plan A hardly ever goes to plan. So, like I said, we're going to be guiding that head as it rotates. From there, we're going to go down, supporting the head, get that top shoulder out, okay? And then from there, we'll lift just a little bit. We're not lifting, but just a little bit of upward motion, get the bottom shoulder out, and then usually the whole thing slides on out pretty quick, okay? Do not pull them from the birth canal, and then remember they're gonna be slippery. That white kind of gunk that's on them, that's vernix caseosa. Okay, and it's really slippery, okay? So just keep that in mind. Slippery footballs, do not drop babies. People don't like that. For go ahead, question? No? Okay, I'm just tripping. Okay, if the mother is able to and willing, place the newborn on her abdomen so skin-to-skin contact can begin immediately. I've also heard chest, but regardless, we want to get bare skin to bare skin. The reason you want to do that, one, warms the baby, right? Mom's going to be warm the baby. But two, it starts to stimulate the uterus shrinking. It starts to clamp off the blood supply. Okay, because they get that hormone release once they have skin to skin with their child. It starts vasoconstricting the uterine vessels, so the bleeding starts slowing down. Okay? Huh?
The body's just really cool.
Yeah, it's pretty neat. When the baby comes out, dry off the newborn, wrap them in a blanket or towel, and then wrap them so only their face is exposed. So you know how back in the day, everyone's kind of heard of this? When they think of a baby being born, they think the doctor holding them up by the feet, give them a little slap on the tush and they cry, right? That was a stimulation. Well, we can do that, not that, you're not ever gonna do that, but we can stimulate the baby with that towel. Okay, we gotta dry them off because they're covered in that gunk. It's gonna be cold. So drying them off warms them up. But also when you're drying them, you're stimulating them, right? You're gentle, but you're not the most gentle. You're trying to make sure you're stimulating. Piss that kid off a little bit. Let's make them cry. Because a crying baby is a breathing baby, and a breathing baby is a living baby. That's always good, right? So as we're drying, stimulate at the same time. Remember, we can do a lot of things at the same time and get a lot of stuff done fast, okay? Questions on that?
What about with like the kids that are born with an issue and have to go right to the eyes?
NICU?
Yeah.
I mean, we're not in the hospital, so we just got to get them there, and we're going to take them straight in there, right? But for us, once we have a baby delivered, we're going to L&D, and then let L&D above our pay grade make the higher choices, right? The tougher decisions leave to people with higher scopes.
But like in the reference of like the skin-to-skin thing, like how does that?
This is what, sorry?
In referencing like the skin-to-skin contact,
Mm-hmm.
if they don't get that, like do they just keep bleeding? Or?
I mean, there's meds we can push and things like that. There's also, that's where fundal massage comes in, and we'll talk about that.
Okay.
Yeah, there's other things. Yeah, Hayden.
When you get to the hospital, mom is not walking the baby in.
No, mom's not walking at all. No.
So one of the EMT medic would walk the baby in.
No, we're going to put baby on mom. We're just going to roll her on the gurney.
roller.
Yeah. Yeah, no, baby will just be on mom, we'll roll her in with the gurney. Very good. Okay. So, wipe the mouth, sterile gauze pad as needed. Remember, we're looking for that meconium, that greenish, foul-smelling stuff, because that's baby poop, right? And that's the big one with suctioning the mouth and nose, especially if there's meconium. They've got stool in their airway. It's an aspiration risk, okay? So you're going to clamp and cut the umbilical cord approximately 60 seconds after birth. Okay, when it comes to clamping it, give yourself about a foot and a half of cord room. Okay, so from baby to cord, clamp, about 6 inches, clamp, we're cutting in between. For a long time, there was always talk of, well, we should milk the blood into baby, we should milk the blood back into mom. Not a lot of great science going either way to credit that. So I would say just don't do it, okay? Just cut the cord, let the doctors and the nurses do the things they do best. Okay, let them make those choices. And then you got to get a 1-minute APGAR score. I'll talk all about APGAR here in a moment. I'll show you what the table looks like, okay? But you're going to get two. You're going to get a 1-minute and a 5-minute APGAR, okay? So for delivery of the placenta, we're only assisting, okay? We're just hanging out. We're getting ready for that thing to pop itself out. The placenta will deliver itself, usually a few minutes of the birth or within a few minutes of the birth, and then we're never tugging on the umbilical cord to try and get that out, because remember, it can take upwards of a half hour for that placenta to separate, and if we're starting to pull on it, we run the risk of maybe tearing it away. Okay, so we don't want to pull on that umbilical cord. Just leave it be, the placenta will show up, okay? Okay, so to your question, help slow the bleeding. This is the idea of fundal massaging. So we can help slow the bleeding by gently massaging the woman's abdomen with a firm circular kneading motion. Okay. Now, the word gently is not the word I would use to describe this process. Okay. It's pretty violent, a little bit. When you're getting in there, you're really pushing in on that uterus. You're trying to get the uterus smaller, get it to contract and constrict up. Smaller the uterus gets, smaller the blood vessels get, less bleeding shows up. When I saw doctors do this, when I say violent, I mean violent. They put their fist in there and they were just twisting their fist in this woman's abdomen. She stopped bleeding though. It worked, okay? One of those things, hard to complain about pain if you're dead, right? And also, probably want to stop bleeding anyway. And this, honestly, for what I'd imagine, as much discomfort as you're feeling while they're doing that, I could imagine it makes them feel a little bit better after because they're going from like distended to smaller. The only close comparison I can think of is like when you've eaten way too much food and then you take that poop and then you feel empty inside a little bit, you know? You all know what I'm talking about. Don't act like I'm crazy, okay? That's what I imagine, that like relief sensation. I'm not crazy. Not crazy. So, record the time of birth. Be better than I am. I always forgot that. You don't want to mess up too many star charts out there, right? So, make sure you're recording time of birth, usually within the minute. When we birthed that one child, it was one of those where it was like, hey, what was the time of birth? 10:10. We'll just make one up, okay? So, following emergencies is when we start having issues. Okay, so more than 30 minutes have elapsed and that placenta is not delivered, we got problems. If there's more than 500 milliliters of bleeding before the delivery of the placenta, that's a problem. If there's significant bleeding after the delivery of the placenta, problem, right? So this is where getting ALS on the horn and getting them en route will help. We have medications we can push, one of them being Pitocin. Pitocin is a natural hormone that the female body produces when they have children. It helps with that constriction, the vascular constriction stops bleeding. We also have a medication called TXA, tranexamic acid, which helps with clotting. Okay, so we can help to stop that bleeding. So for neonatal assessment and resuscitation, okay, so the first minute after birth is known as the golden minute. Okay, so during this time, perform the initial steps of newborn care. So get the airway position suctioned. I've heard mixed reviews or a couple of different opinions when it comes to when to suction. I've heard, you know, if to suction as soon as you see the mouth and nose, just bam, 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 get it done with. I've also heard wait till the full body is delivered, then suction really quick. Kind of leave that up in the air to you. For me, we didn't suction immediately as she was coming out. We suctioned when the baby was born. Had there been the presence of meconium, maybe that shifts my gears a little bit, right? Maybe I'm like, we'll be quicker on it because there was meconium in the fluid, so I know they might have stuff in their mouth. Let's just get it done with early, okay? So get that airway suctioned, dry them, warm them, tactile stimulation. We can do all of that with one towel, okay? Once we've dried them off, slip their little hat on, wrap them in a blanket so only their face is exposed, give them to mom. Now, I know there's kind of a discrepancy here and I can feel it a little bit when it comes to skin versus drying them off, wrapping them in a blanket. Usually what happens, baby's born, dry them off, immediately skin to skin with mom, okay, cover it with a blanket. Once we've got enough skin to skin, maybe a couple minutes, then we're gonna wrap it all up. Or maybe while they're doing skin to skin, we start putting the hat on, we start wrapping the blanket around the baby, okay, and then we can just always reposition them, okay? Make sense? So you can either use the chest or the abdomen for that skin to skin, but it has to be bare skin to bare skin. To the same point that even fathers do this. Fathers can provide body heat to the babies, so it's not uncommon when babies are born for the father to do skin to skin also. That also is known to happen. So normally the newborn will begin breathing within 30 seconds after birth, and the heart rate will be 100 beats a minute or higher, okay? If they are not breathing, positive pressure ventilation. Okay, remember kids are breathers. Their oxygen demand, cellular oxygen demand is high. They need a lot of oxygen, okay? I saw a video the other day of a guy, it was a doctor. Baby was born, needed resuscitation, and he just sat there bagging it. And then he would like check responsiveness, just kept bagging it over and over, checking responsiveness, making sure he had his stuff ready. And eventually you start to see that baby stir and kicks into life, okay? So oxygen is our fix a lot of the time. Okay. Now, many newborns are going to require some form of stimulation. So positioning their airway, drying, warming, suctioning, or tactile stimulation, they're gonna need something to stimulate those breaths, okay? I'm not sure if there's a for sure answer, but when I was in medic school, there was kind of a discrepancy of we're not sure when or what causes the child's first breath. We don't know if it's they feel that air on their face for the first time, or we're not sure if it's the chest being cleared from that vaginal cavity and now it has chest expansion ability. It's kind of a back and forth. So that's also part of that suction discussion, right? We don't really know when they're gonna start breathing, so figuring out your suction as soon as we can is important. And a table, okay. Now, one thing again, going back to that, they come out, they should be at 100 beats per minute. If we're at 60, what are we doing? CPR, right? We're starting compressions, doing CPR if they're at a heart rate of 60 at birth. Now, observe the newborn for spontaneous respirations, skin color, and movement of the extremities. Those are the factors that we will use when we calculate an APGAR score. And I'll show you in a moment what that APGAR table looks like, okay? Now, another cool thing about the umbilical cord, remember it's got 2 arteries and a vein. We can check a pulse on their umbilical cord, okay? You don't actually have to grab the brachial. You can feel their umbilical cord, yeah, that's his own artery, own heartbeat. So, or the brachial artery, or, you know, small babies, smaller, even smaller arteries. You can use a stethoscope, just listen to their heart, okay, and see how many beats a minute you're counting, okay? It's kind of the same thing as a pulse, okay, finding the same numbers. So if chest compressions are required, use the hand encircling technique for 2-person resuscitation, okay? So these are gonna be small babies. Your hands are gonna fit around them. We're doing that 2-finger or 2-thumb wrapping around, okay? This is gonna be one of the few changes we have to CPR though. Okay, instead of it being a 15 and 2, right? 2 rescue or pediatric, 15 to 2 normally, it's a 3 to 1. Every 3 compressions, 1 breath. What are we prioritizing with that? Compressions or breaths? Breaths, right? Because we have more frequent breathing going on because once again, kids half the time their problem is oxygen, okay? So this leads to, you know, per minute, if you're doing 3 to 1, 120 total actions, 90 compressions, 30 breaths. Okay, and then hands-only CPR is not as effective as ventilation with CPR, especially with kiddos, okay? Typically with them, it's not just a heart problem, it's an oxygen problem, okay? So ventilating is gonna be very important. You will have a neonate-sized everything, okay? BVMs, SpO2 monitors, even as much as like advanced airway adjuncts or LMAs, they make LMAs this big. Or not LMAs, excuse me, OPAs. They make teeny tiny OPAs and MPAs, okay? Those are gonna be also used as needed. So hand encircling, right? 2-person CPR, 3 to 1 ratio. Remember 3 to 1 ratio, that is going to come up at some point, I promise. But make sure if you're gonna choose 3 to 1 as an answer, we're talking about neonates or brand new babies, okay? Anything north of that age-wise, 15 to 2. Okay. If meconium's present, newborn's not breathing, quickly suction newborn's mouth and nose, then quickly deliver after providing rescue ventilations. Or what? Quickly suction after delivery, sorry, before providing rescue ventilations. Okay, so the APGAR score. What are we looking for? So the APGAR is the standard scoring system used to assess the status of a newborn. Okay, and there's 5 areas that we calculate. There's the appearance, there's the pulse, there's the grimace, otherwise known as irritability, there's activity, otherwise known as muscle tone, right? And the last one's respirations. If we break down the first letter, that spells APGAR. Welcome to the APGAR score, okay? So there's a table coming up. So a total of 5 numbers. The perfect score is 10, okay? The worst score is 0. Calculate the APGAR score at 1 minute and at 5 minutes. Do not be surprised if when the child comes out, they're not a perfect 10 on the APGAR score, okay? Where we get concerned is if there's no improvement by the time the 5 minute comes around, okay? So the APGAR, so 2, 1, or 0. So when we're talking about appearance, When they come out, their entire body is pink. That is a 2. That is as good as it's going to get. They are circulating, they are perfusing. They're going to get a 1 if their body is pink, but their hands and feet are blue. They have some of that peripheral cyanosis. Okay? That just means the blood hasn't quite reached their fingers and toes yet. Okay? And they'll get a 0 if their entire body is blue or pale. Then we move down to pulse. They'll get a 2 if they have more than 100 beats per minute. They'll be at a 1 if they're fewer than 100 but more than 60. Okay? And then 0 is typically 60 or lower. Because 0, 60 or lower, we got to get involved, compressions, right? CPR. For grimace or irritability, so a 2, the newborn cries and tries to move its foot away as you snap your finger against the foot of its sole. Sole of its foot. If we irritate the kid a little bit, right? Flick their feet. Are they getting pissed off at you? They don't like it? We want that activity. Maybe we flick their foot. Newborn gives like a, that's really it. It's not really trying that hard. We'll give that a 1. And then if we do that same thing, there's no reaction to that stimulus, that's a 0. For activity, newborn resists attempts to straighten hips and knees. Okay, so as they're we try to flex their legs up, or if they're kind of curled up, maybe we try to bring their legs down. Are they fighting us? We want them fighting us, right? Because they're fighting us, we know they have muscle tone. We know they've got that activity in their muscles. They're perfusing those cells. A 1, newborn makes a weak attempt, right? There's not a lot of effort when we're dealing with that. And then a 0, it's limp. There's no muscle tone. We try to manipulate it, and it's just a limp baby. For respirations, a 2 is rapid breathing. Remember, kids' respiratory rates are fast, okay, especially brand new babies. So a 2 is rapid, 1 is slow, and then 0 is not breathing. Okay, so you're going to find a combined score, and you're going to take this twice. Once at the 1 minute mark, once at the 5 minute mark. Okay? Questions, comments, concerns? Okay, now this is something that I would also include, like I told you guys to do with the pediatric vital signs. Just make this a favorite. That way, if you need to pull it up, you can click on it real quick and you have an APGAR score. Your chart will have one, but I can tell you when there's this much going on around you, the last thing you're looking at is your tablet. Okay? So, when assessing the newborn, calculate the APGAR. Stimulation should result in an immediate increase in respirations, right? As soon as we tactilely stimulate that baby, piss it off a little bit, it's going to cause it to cry. If the newborn is breathing well, assess the pulse, and then assess oxygenation via pulse ox, and observe for central cyanosis. We are not as concerned about peripheral cyanosis, the feet and hands, right? We can survive without feet and hands, but it's just going to take a second. We're worried when like the mouth, the chest, those are blue, right? Because that's more central nervous system stuff, okay? And then pulse ox, don't use their fingers. They got teeny tiny little lizard-like fingers. I would use their ear or maybe their big toe. Okay, and these pulse oxes aren't like the ones you think of where they're like clippies. We have stickers, so you can stick it to them, so that way wherever they move, it'll go with them. Request a second unit. The newborn is in distress and will require resuscitation because remember, we have 2 patients. We still have mom to deal with, we still have the baby. In situations where assisted ventilation is required, use a newborn BVM. You will have the properly sized. What do you think we're worried about with the BVM though on a newborn?
Hurting their lungs.
What?
Hurting their lungs.
Hurting their lungs, overinflating, right? So pay a lot of attention to that dial. You guys know the green, yellow, red dial when we have the BVM. Stay in the green, okay? We do not want to vary from that. If the newborn does not begin breathing on his or her own or does not have an adequate heart rate, once again 60 or lower, continue CPR, rapidly transport, okay? I would say if you've got CPR started, you're probably going to start driving anyway, okay? But make sure you let the hospital know the age and the demographics of the patients you're bringing in. Okay, so we're going to talk about some different positions. Now, once again, ease some minds. Most births go fine. If they go sideways positionally, these are the things that we usually see, okay? So the first one, breech. As we're just looking at the picture, we know that baby's upside down, right? Rather, the wrong direction for delivery. We want to deliver head first. So most infants are born head first. Occasionally the butt is delivered first. This is called the breech presentation. We can still deliver this one, okay? This is something we can deliver. There are times where the head gets stuck, right? We might run into problems breathing-wise. Also, this is, I think it's kind of barbaric, but it's a necessary evil. Outside of our scope, we don't do this. It's not uncommon for labor and delivery doctors, if they're in a breech position, to reach in and break one of the legs or break an arm so that the kid can bend to get out of that spot better. Yeah, not uncommon, kind of barbaric, but is that or cut the woman open, wide open, right? And the bones will heal just fine. Where they break them, they're avoiding growth plates and all the things. They're trained to what they're doing, but it is something that does happen, okay? Now, breech deliveries usually take longer, okay? Think about it, the head's the easiest portion to get out of their body or out of the female body there. So upside down is gonna take a little bit more time. So you'll have often time to transport the pregnant woman to the hospital. Now, if the butt has passed through the vagina, the delivery has begun. Okay, we are in it, time to get going. Get ALS backup and then get medical control on the phone. You're gonna want that speaker phone so that they can be guiding you through this as you're dealing with this situation, okay? Now, for preparing for it, not a lot changes. You're gonna get her in the right position, you're gonna get your OB kit out and ready, you're gonna be placing you and your partner as you normally would. Okay, from there, you're gonna allow the butt and legs to deliver spontaneously, supporting them with your hand, okay? Now, when this happens, when breech happens, usually the head is face down, okay, because their butt came out first, so they're backwards. There are gonna be times where the head gets stuck, okay? This is one of the 2 times you're gonna insert fingers into the vagina, okay? First one being their head is stuck, you're gonna make a V with your fingers, you're gonna reach in there and spread apart. That way the baby has an air passage because their chest is out. They can start breathing. We got to make sure their airway is good. So you're going to hold that open, okay? Understand also, if this is your job, you ain't moving. It's just not moving until we get to the hospital. Okay, we got to keep that airway going. And also, once again, being EMT basics, this is something that if I was in a situation where this was going on, I'm making my basic do this because I got bigger fish to fry. I got bigger scope, I got more stuff to do, okay? Any questions with breech? Yeah, Megan.
When you're holding your fingers like that, I'm also you want to be mindful, obviously, not to like poke them in the eye and stuff. Are
Yeah.
you doing it where their face is, or are you doing it
Yeah, so,
close?
well, because you're going to see their body, right? You're going to see their body in the head, so you're going to go low as you can. You're almost going to be doing like this number to the bottom, and you're going to like insert, push low, and then wide, and then find the face with the backs of your hands. Just be gentle, right? So the backs of the fingers.
Okay.
Mm-hmm.
I'm confused about that. Like,
Okay, so they're in this butt first position.
Right.
Remember, they're going to rotate when they deliver. So as it's delivering, it's rotating. So the legs are out, but now the head is stuck face down in the vagina. Their chest is out. They could take a breath. Where's their air? What air are they breathing? Right? There's no air available because they're.
the only thing that's out.
No, the body is the only thing that's out. The head's the only thing that's in. So when the head's the only thing that's in, you're going to form a V with your fingers in the vaginal canal there, so that you can open it up basically around their nose. Okay, so you're basically doing this number right here to them, so that they have this kind of air passage.
And the baby's like on your arm.
Essentially.
Okay.
Yeah. Yep.
Sorry, I wasn't getting that.
No, you're good. You're good. I'd rather take the time to clarify than not. Okay, the next one, limb presentation. So on rare occasions, the presenting part of the fetus is a single arm, leg, or foot. This is called leg presentation. Limb presentation, that's leg presentation. Limb presentation. I've never seen this one. I always imagine that I'd probably be the worst person to have in the room here, because if it's a hand, I'm gonna walk by and high five that sucker on the way out the door, and I'm probably gonna get kicked out of the hospital. But I've never seen this one personally, okay? Now, a fetus with limb presentation, we cannot deliver this in the field. This is a surgery. They need a C-section. Think we can deliver that baby? Nope. Jeez. Nope. So, transport immediately, cover the limb that's protruding with a sterile towel, just keep them warm, okay? We're never trying to push it back in or pull on it, okay? It's stuck where it is. And then place the patient on her back with her head down and pelvis elevated. Let gravity be counterproductive to this birth, because remember, we can't slow or delay delivery. okay? So, but gravity might be able to help. So if we can elevate them, maybe we pat under their back so that gravity is pulling that baby back down. It'll just slow it enough for us to get to a hospital in time. Make sense? Okay. The next one, prolapse cord. Okay, so the prolapse of the umbilical cord must be treated in the hospital. So this is basically where the cord came out of the vaginal canal before the baby. Okay, so the umbilical cord comes out vagina before the fetus, like I just said. Okay, well, what did I say about the umbilical cord? How important is it to that baby? It's their lifeline, right? Do you think that baby's smashing that umbilical cord right now? Absolutely, right? That's a problem. It's disrupting its own circulation. Second time, you're gonna insert fingers, okay? So the fetus's head will compress and cut off circulation. So do not push the cord back in. Instead, we are going to insert gloved hand, once again, sterile gloves, gloved hand, into the vagina, find the fetus's head, being wary of soft spots, eyeballs, things of that nature, okay? And you're just gonna lift that head off of the umbilical cord. You're gonna find your cord, follow it along until you find the baby, and then just lift the head. You might have to flip your hand around a couple times, figure out what's gonna work best, okay? But then also, same thing, once that's your job, that's your job. We ain't going anywhere, okay? Gotta make sure that baby stays perfusing. So this is one where we can do the same thing, place them on supine, foot of the cot raised higher than the head, hips elevated, or there's another one, the knee to chest position. So we're gonna literally put them on their hands and knees, butt in the air, on the way to the hospital, and it was described to me as that's a way you could potentially slow down labor. It still feels kind of sketchy. I would tend to go probably with the elevated hips before I put them in that position, because there's a lot more motion going on and looser joints, weird center of gravity. A lot of things can happen in that motion, especially if we're in a moving 6x8 box, okay? And then transport rapidly. So, out of all of these weird presentations, which two can we deliver? Or which one can we deliver? Breech. Can we deliver, or with a nuchal cord? What do we do if we have a nuchal cord? Cord around the neck. Try to slip it over. If we can't, what do we do? Clamp cut, making sure we don't have multiples. If we have limb presentation, can we deliver that one? If we have the cord first, can we deliver that one? No, on paper we cannot. Reason being is we don't want that ripping on the way out, right? If the baby's already smashing it and it beat the baby out the hole, we're gonna have problems, okay? So these ones we are not gonna transport. Okay, spina bifida. So this is just it's a congenital defect. Okay, so developmental defect in which a portion of the spinal cord or the meninges are protruding outside of the vertebrae. Okay, so they're visible on the back of the head. If you see this, you're gonna cover that area with a sterile, moist dressing, okay? Remember, babies don't have a lot of temperature, and if you're gonna be putting something directly, basically on their nervous system, how hot or cold do you think that towel should be? Right? We don't want too hot, we don't want too cold, we don't want to damage that tissue at all, and we don't want the baby to lose temperature. So just try to get something that's kind of warm, lukewarm, okay? Maintenance of body temperature is important when applying moist dressings, okay? We got to make sure we're maintaining that body temp. Multiple gestation. So twins occur once every 30 births. Okay, fairly common. Twins tend to be smaller than the single fetus, and delivery is typically not difficult. They're gonna be smaller because it's two babies taking up the same space, right? So they're just gonna be a little smaller, they're gonna grow into normal sized people, okay? So about 10 minutes after the first child is born, contractions will start again, and then the birth process will repeat itself. Second one is usually born within 45 minutes of the first. I'm sure some of you guys have met twins before or know twins, and they probably argue about who's older because it's like a separation of 15 to 20 minutes, right? But yeah, just understand once one baby comes, the next baby's coming out, right? Now, the procedure is the same for that of a single fetus. Record the time of birth for each of them. And then twins may be so small, they look premature. They're not premature, they just took up the same space and they grew together. So they're not gonna get as big in the womb. For premature birth, so normal term normal full-term single newborn will weigh about 7 pounds at birth. Do you have a question?
Yeah, about twins.
Yeah.
With the placenta,
Mhm.
are they both attached to the same placenta? So you would deliver both babies and
Yeah.
then receive a placenta, or how does that work?
I want to say they have one. No, I want to say they have two.
Okay.
I'm not entirely sure. We'll Google that one before you leave. Yeah, I can't remember on that one. I know I've learned about it, I just cannot recall. So a normal full-term single baby usually weighs about 7 pounds. Okay, so a newborn who delivers before 8 months, so before 36 weeks, or weighs less than 5 pounds at birth is considered premature. Okay, once again, premature babies can grow into full babies. Yeah.
The twins,
Yeah.
depends on identical or paternal.
Oh, which one's which? As far as
Share the same.
share the same.
70% of
Yeah,
identical
70%
twins
of
may
them.
end up sharing the same placenta, but fraternal have separate.
Interesting. So I guess it depends. That's good to know. Good to know. I'm going to include that in my stuff. Thank you. Yeah, so premature newborn. The one on the right there is going to be your preemie. The one on the left, full term. Okay. Premature newborn, smaller, thinner. The head is proportionally larger, right, in conjunction to their own body. Now, because they're early, the vernix caseosa will be absent or very minimal because the mother's body didn't have as much time to prepare. And then premature babies typically born with less body hair. Okay, some babies come out looking real fuzzy. My niece had arm hair, it put me to shame. So, premature newborns usually require special care to survive. These kids often need resuscitation efforts, okay, which should be performed unless it's physically impossible. And I can't think of a good example of when it would be physically impossible outside of the world is ending or there's a car crashing into the house you're birthing this baby in, okay? For the most part, you're gonna have time to resuscitate, get involved. So with care, premature newborns as small as 1 pound have survived and developed normally. I have a good friend of mine, works for Boise Fire. When we were learning about this in medic school, he's like, I was a preemie, which just really opened the door to make fun of him. It made it too easy. But he's an example of premature baby growing into a fully fruitioned person, okay? But checks out on a lot of fronts. So, and then post-term. So pregnancies lasting longer than the 41 weeks. Fetuses can be larger, sometimes weighing 10 or more pounds. Okay, so think about they're past their point of development, but they're gonna still keep growing and developing. Okay, so this is when we start seeing meconium and things of that nature. The baby's gonna be big. That 18-pound baby was like 3 weeks late that I was telling you guys about, okay? So can lead to problems with the woman and the fetus, especially if we're talking labor and delivery. A couple of friends of mine just had their baby as well last September, I wanna say. Basically, his wife was in labor for 24 hours trying to push out a 12-pound baby, or 10-pound baby rather. And it got to the point where eventually they tried and tried and tried to have a natural birth. They were like, cut it out, we're done with this whole game. Okay, you can try for so long, but if they're just too big, they're too big. Okay, that's just the way it goes. Now, increased chance of injury to the fetus, the bigger they get, right? Especially if they're taking up more of that amniotic space. There's less amniotic fluid to buffer them, contact can hit them. Increased likelihood of a C-section. Woman is at an increased risk for tearing. If they tear, there's infection, okay? Post-term newborns have increased risk of meconium aspiration, infection, and also being stillborn, okay? I'll come back to that one. Now, these newborns may also not have developed normally, okay? Depending on the size of their mother, dictating how much space they have to grow, right? Can start impeding some stuff. So being stillborn, so baby is born non-viable, even CPR, baby is gone, okay? I know a lady it happened to fairly recently, like within the last 2 years. Essentially what happened with her was that the baby was on schedule. Like her due date was like on a Sunday. It was the Friday before that Sunday, so I had a family dinner. Everyone's excited about it. Wakes up Saturday, something feels wrong. She's like, it's not moving, something feels different. Turns out, they go to the doctor, she goes to the doctor that day, heartbeat stopped, baby is dead. Well, what had happened was that her body was starting to reacclimate to becoming not pregnant again. and our livers produce enzymes that can be cardiotoxic to babies. So her liver started to overwork for the point her body was at, produced an enzyme, got into her blood circulation, killed her baby. It happens, okay? People do have stillborn babies, but there's all sorts of reasons. That's a specific one with her, but there's all sorts of reasons it could happen, okay? I will say if you are delivering a stillborn, it is not gonna be a good time, okay? Just keep that in mind. It's gonna be a very emotion-fueled moment. Yeah, Sam?
So with that scenario, would her, like, if she got pregnant again, would that enzyme release again, or is it just?
Well, she's pregnant again right now. I don't know. I mean, it's happened before. It could happen again, but I don't know if she's doing like prenatal care or something to like supplement now, because now we know this is a problem. How do we fix it next time? But I'm not quite sure, and I don't really want to talk to her to ask. So.
What is the like percentage of people that?
What?
What is the percentage of people like that have a successful birth versus like?
I don't know the exact numbers, but I would assume successful is a lot higher than you think it is. Because once again, people have been birthing babies for thousands of years. Most of the time, they go find, a lot of people deliver in their own homes, right? Yeah, Sophia.
Is that common in liver enzyme? Like
I don't know. I'm not super sure on that. I honestly have not heard a lot of experiences personally with stillborns. I just don't know the statistics behind it. But I know it happens. I wouldn't say it's necessarily common though. Just because knowing births usually go fine. Yeah, right.
If you get a stillborn child, is there like signs to tell you that like this child is beyond resuscitation efforts, or is it just you proceed with neonatal resuscitation?
Usually it's going to come out pale, maybe mottled, right? It'll have like your traditional signs of death.
Okay.
Mm-hmm.
So, but you would then get on the horn with medical control?
Yeah, you're probably going to start resuscitation efforts. Get on the horn with medical control. Tell them what you have. They're mottled. They're cyanotic. Blah blah blah.
Yeah.
This is our 1 minute APGAR 0, 5 minute APGAR 0.
Yeah.
Pretty sure. Then I mean, we have to work it for liability reasons,
Right. Yeah.
but you're probably going to call it fairly quick. Mm-hmm.
So, sorry.
No, you're good.
Does that have, like something to do with like, because it sounds like a lot of like miscarriages are pretty common.
Mm-hmm.
So
Yeah,
I know that's
miscarriages are
way
common.
earlier, but like, does the body like not reacting to you being pregnant correctly? Is that like the more so the reason of that, or is that
For miscarriages,
Yeah.
there's, for what I understand, a plethora of reasons. Things like high stress. Like I know a medic who had a miscarriage, and she blames the stress of the job. You know, so there's all sorts of different factors that could play into that. Also, just overall general health of the mother beforehand too.
But
Right?
it wouldn't really have anything to do with like the liver situation.
No, not that I'm aware of. Honestly, that's the first I'd heard about it, and it was like, well, that makes sense why it's a stillborn. So I was just looking for reasoning, but there's lots of reasons to be stillborn. There's all sorts out there. Yep. Cool. Bring the temperature back down again. Fetal demise. So you may deliver a fetus who died in the woman's uterus before labor, stillborn. Onset of labor may be premature, but labor will progress normally in most cases. If an intrauterine infection is what caused the demise, you may note a foul odor. And then do not attempt to resuscitate an obviously dead neonate. That's where I kind of have problems, right? Like from a legality standpoint, I need to make an effort. But also, if we have obvious signs of death, you're gonna have to muddle through a very uncomfortable situation. Okay, yeah, Isaac.
Can the umbilical cord like become unattached while inside the?
Mm-hmm. Yeah, the umbilical cord could probably separate. Think about trauma, right? Like, I don't know if it's like spontaneously just popping off there. I wouldn't think that's true, especially because it's vasculature. I'd assume more trauma-based stuff to cause something like that. Does that answer your question?
Yeah.
What do
Okay.
you do in that scenario? If it's like a car crash and it
We're not gonna know any better, right? I can't see inside, so I don't know what's going on. Just transport as fast as we can, manage the trauma, be ready to treat for shock.
And could this potentially cause like an infection if, you know,
Yeah.
like the, okay.
Yeah, or maybe they got an infection prior. Like it says, could be what caused the death, right? But yeah, I mean, it's an open source. If you're delivering to the world, that's an open space to your internal organs. Could be an infection risk, right?
But like if you're stillborn, sorry.
No, you're good.
If you're stillborn that's like dies and doesn't get like taken out soon enough. to not
Oh, well,
progress.
like, yeah, it's like if you get toxins in your blood, essentially. Yeah.
So you mentioned with the miscarriages, you put the fetus in the bag,
Mhm.
but for like a full stillborn, would you just give it to the mom?
Usually just give it to mom. Yeah, you probably are still gonna wrap it with a blanket, cover its head, and just give it to mom, and then stay out of the way, let her do her grieving process. But obviously, within certain boundaries, make sure she's not gonna harm herself or others, that kind of stuff. Yeah, good question. Okay, so let's get into, I think these are the last little bit here. So postpartum complications. If bleeding continues after delivery of the placenta, you're gonna continue that fundal massage. If it's not working, check your hand technique, check your hand placement. If bleeding continues, there's a lot of different methods to do this. I would YouTube some. Okay, that's what I would recommend. Excessive bleeding, usually caused by the uterine muscles not fully contracting. We want those muscles contracting down because when the muscles contract, it clamps off blood vessels, and that's gonna stop the bleeding. Okay. We're gonna cover the vagina with a sterile pad. If there's a lot of bleeding going on, you're gonna change the pad as often as possible. If it becomes saturated, like it's being bled through, start swapping it. Same idea, we're talking about gynecologic bleeding. You're gonna throw it between their legs. You're not gonna throw it away because the doctors and the nurses can look and see how much blood they lost so that they can know how much to reconstitute for the patient. Okay, so don't discard. And administer oxygen, monitor vitals, transport immediately. Okay. Another thing, postpartum patients are at an increased risk of an embolism, most commonly a PE. So remember when I said these blockages don't have to be blood clots. Amniotic fluid can cause a blockage. Air can cause a blockage. We're gonna have open vasculature to the world. Can get stuff in there, okay? Now, result from a clot, travels through the bloodstream, becomes lodged in pulmonary circulation. We know what a PE is at this point. Just think about anything entering systemic circulation that should not be. Where's it gonna land? If it's a vein, it's going through this inferior vena cava, right atria, right ventricle, shot out to the lungs, okay? And then consider a woman who complains of sudden difficulty breathing or shortness of breath following delivery to have a PE. That's what we're thinking. If they deliver and they're like, I just really can't catch my breath, I'm starting to get some pain, thinking PE. We're still driving fast, not a lot's changed, right? But maybe we're starting to prep with a little more oxygen. Let's get them as ready as we can for multiple complications and make sure you're keeping the hospital in the loop so they know what we're showing up with, okay? All right, that is lecture for the day. So.